To those who have joined physically here as well as online, and welcome to the one-day workshop on current updates on neurology collaboratively organized through the Candy Society of Medicine and the Association of Sri Lankan Neurologists. Now, I'm sure that you're much aware about the Candy Society of Medicine, which is a fairly old professional organization, medical. And our theme this year is actually going well with this, the scope of activities happening today, guiding the society through science in managing non-communicable diseases. So when I spoke to Dr. Gamini Patirna, who is the president of the Association of Sri Lankan Neurologists, I'm very happy to say that his cooperation as well as the team's in getting this through was very commendable. And we organized this much earlier, few months back, but due to COVID, at the last moment, we had to postpone because of the COVID escalation. And we had very much sort of doubt whether to go ahead. Ultimately, we decided that it's better to have physical presence for this kind of thing. Ultimately, somehow, we had to continue without that in mind, but to make it happen. So let me welcome all of you as well as thank helping us in and today there are very eminent speakers taking part in this symposium covering very timely topics brain acute ischemic stroke as well as peripheral nerve dysfunction, then also epilepsy, etc., vertigo and spinal cord syndromes. And we had the collaboration a few months back regarding the collaborative program with the SLMC on stroke management, that capacity building program. And that also went very well. And I'm thankful to Dr. Gamini Patirna, who was a resource person at that time as well. So thanking again to extending this cooperation. To also, I expect last year also this happened as a certificate course, and I'm sure that in the future also this collaboration will be fruitful. Therefore, on behalf of the Candy Society of Medicine, I thank you very much. And then I can hand over to Dr. Gamini Patirana, the president of the Association of Sri Lankan Neurologists, to speak a few words on the inauguration of this event. Thank you.
Good morning. Thank you very much, Professor Manjula, for the kind words. I think I can be heard from your end. I hope you can hear me. As Professor Manjula mentioned previously, the same program had to be cancelled because of the Delta. And currently, I think we have meticulously found a gap between Delta and Omicron to have the program going. If you had to change the date a little bit later, maybe you would have probably met the same situation. So the subject of neurology keeps changing very fast, especially in stroke neurology. And it's always necessary to keep update with the neurology topics because neurology is everywhere, and every discipline in medicine, you will encounter neurology. So it's always necessary to have an update in neurology. And thank you very much for having collaborative sessions in neurology even in the past. And we will probably have future events as well in future. Hope next year we'll have a physical event free of COVID. So as Professor Manjula was mentioning, we have lined up a great session today, excellent mix-up of speakers and topics. And I must thank Dr. Manjula Caldera from our end, Secretary of Association of Sri Lankan Neurologists, for coordinating the speakers and this program. So this event is a hybrid event, not only from the fact that we have virtual and physical participation. We have two esteemed associations getting together here, And of course, we have found a gap between Delta and Omicron. And also we have a link between Colombo and Candy Neurology. So hope you will have a great session today. Unfortunately, I will not be able to be with the program for the whole day because of the busy schedules, but you will be having with great speakers from extreme senior eminent speakers down to the fresh ones. So wishing to have a full physical meeting next year, and also to wishing you enjoy the program today. Thank you very much.
Start the academic session now. First, let me introduce the at diagnose and what is the new invention of brain. Dhammika, over to you.
Good morning, everybody. So the second topic for today is what's new in management of migraine. Before moving in any further, I know we all have come across patients with migraine. We all have patients. So what's the current understanding of migraine pathophysiology? Activation of the trigeminal vascular system is believed to be a primary pathway leading to the pain associated with migraine. The system is comprised of nociceptive nerves from the ophthalmic region of the trigeminal ganglia, the major vessels responsible for regulating cerebral blood flow, and the smaller vessels in the meninges. Activation of trigeminal ganglion nociceptive neurons and the subsequent release of CGRP is implicated in migraine pathology. Results from studies support an important role of CGRP in the development and maintenance of peripheral sensitization of trigeminal ganglion neurons and central sensitization of second-order neurons, which are key pathological events associated with migraine. Given the central role of CGRP in migraine, blocking the physiological effects of CGRP would be a logical therapeutic target for treating migraine. CGRP exists in two forms, alpha and beta. They are derived from separate genes and differ by 3 amino acids, yet exhibit similar biological effects. Alpha CGRP is the main form expressed in trigeminal ganglion neurons and the form most essential to migraine pathology. CGRP receptors are expressed by multiple different cell types within the nervous system, cardiovascular system, and immune system as well. So what are the evidence we have to support the role of CGRP theory in migraine? CGRP levels in the cranial circulation as well as in saliva are increased during a migraine attack. Of migraine headache by sumatriptan and other triptans results in the normalization of CGRP levels. And infusion of human CGRP can provoke a migraine attack. intravenous administration of potent CGRP receptor antagonist olgoceptan could abort acute migraine. So this is how CGRP is implicated in the pathophysiology of migraine. CGRP is a key transmitter in for the central sensitization, peripheral sensitization, and to maintain the neurogenic inflammation. So it acts at the level of the meninges and in the trigeminal ganglion and in the brain stem and the thalamus as well. So the proposed mechanism of action of the CGRP antagonist targeted in two levels at the meninges and the trigeminal ganglion. CGRP, calcitonin gene-related peptide, was first identified in 1982. It's a potent vasodilator and a transmitter in the peripheral and central nervous system. Release of CGRP in the dorsal spinal cord has been associated with nociceptive transmission and release from perivascular vasodilatation. So if we are going to target CGRP as a potent emerging treatment for migraine, there are three ways which we can do it. So with the CGRP release and its receptor, the signal transduction starts. So what we can do is we can introduce an antibody targeting the CGRP molecule, or we can introduce an antibody targeting the CGRP receptor, or we can introduce an. We have a couple of CGRP inhibitors at the moment. Monoclonal antibodies targeting the CGRP receptor, eranesumab, and monoclonal antibodies targeting the CGRP molecule, eptinezumab, fremanezumab, and galcanezumab. Those are the examples we have at the moment. Currently, 3 CGRP inhibitors are being approved. The first one was approved was iranobab, that was in 2018, and fremanezumab and the other two which are approved at the moment. JPANs are small molecular drugs which block the CGRP receptor and are still being investigated for both migraine relief and prevention. Unlike monoclonal antibodies, they rapidly penetrate the brain, so work quickly. However, they are metabolized in the liver. So there is a higher potential for interactions and possible liver damage. They are at the moment not being used as migraine preventative therapies. So the possible mechanism of action of CGRP receptor antagonists are inhibit brain transmission. So there are various proposed mechanisms of actions of the CGRP antibodies, which I'm not going to go into any further details. Basically, what they do is they reduce the inflammation, reduce arterial dilation, and they reduce pain transmission. Targeting CGRP is a new, distinct treatment and is a mechanism-specific treatment in the sense that the CGRP may be the mechanism of migraine. Now, when I say this, none of the currently prophylactic treatments are disease-specific. All those medicine that we use for migraine prophylaxis are meant to treat some other disease, and we have found out that they work for migraine as well. So this is, if this works, or if we are going to use this, this is going to be the first disease-specific preventative treatment for migraine. So what are the trial evidence? Evolve-1, evaluation of galcanezumab for the prevention of episodic migraine. Now, there are various trials. I will go through the trials which have been done on galcanezumab for your. So this is a randomized, multi-center, double-blinded, placebo-controlled phase 3 study of 2 dosing regimes of galcanezumab among patients with episodic migraine. Remember, now this is for episodic migraine. Treatment with galcanezumab significantly reduced monthly migraine headache days by 4.7, and the side effects were significantly less, and they have detected that there's no clinically significant difference between the two dose regimes of galcanezumab. These are a few illustrations to show you the results. So there was a clinically significant placebo and the 2 doses of galcanezumab in the number of migraine headache days, the reduction of number of migraine headache days, and the 50% response rate for galcanezumab was significantly higher than it compares to placebo. The migraine headache days again significantly less compared to the placebo. Evolve-2 is a phase 3 multi-center placebo-controlled double-blinded randomized clinical trial analyzing the efficacy and safety of 2 dosing regimes of galcanezumab in patients with episodic migraine. So they have detected that the patients with more than 50% and more than 75% response and more than 100% reduction in monthly migraine headache days, they have detected a clinically, statistically significant difference. And the quality of life, again, they have detected that there's a significant difference. And the change in the migraine headache days, the severity rating, all have shown significant improvements with galcanezumab. And the disability assessment score again has shown a significant improvement with the treatment of side effects. Serious side effects are very much less. Deaths 0. Discontinuation due to side effects are also less with galcanezumab. These are the listed side effects. I'm not going to go into any detail, but as you can appreciate, there's no major clinical problems with galcanezumab. So REGAIN is a study in the prevention of chronic migraine. It's a phase 3 study with 3-month double-blinded placebo-controlled treatment and a 9 months. So again, they have detected reduction in migraine headache days are significantly better when compared to the placebo, and when compared to the placebo, the 50% response rate and 75% response rate all are significantly higher among the group who received galcanezumab. And these are study to compare 50% responder rates among few monoclonal antibodies. As you know, there are variations in the response rate, but all have shown a good response. Blocking CTR, efficient than current treatments. Preventive treatment options for migraine include antihypertensive drugs, antidepressants, and antiepileptic medications. In contrast to CGRP than migraine, this of course I have mentioned you earlier. But it is estimated that less than 50% of patients of prophylactics experience a 50% reduction in their monthly attack frequency. So now we are going to compare topiramate versus CGRP blockers. Topiramate was proven efficient as a preventive treatment of episodic migraine after positive results from 3 randomized multicenter placebo-controlled studies. Thus, topiramate is currently recommended as a level A medication for prevention of episodic migraine. When you compare topiramate versus CGRP blockers, in topiramate, reduction of monthly migraine days was about 1.8 to 2.6. And the 50% responder rate was 37%, 7 to 5%. But in CGRP arm, the reduction of monthly migraine days ranges from 2.9 to 3.9, and the 50% response from 56% to 62%. So you can appreciate both are efficacious, but the CGRP arm is slightly top. Compared to topiramate, adverse events are also generally mild and less frequent. Upper respiratory infections, nasopharyngitis, and injection site pain have so far been the most frequent reported adverse events. In contrast, reported adverse events of topiramate, such as taste disturbance, weight loss, anorexia, fatigue, memory problems, and paresthesia, were more common. Receptors are abundantly present in both vasculature and in the peripheral and central nervous system and are involved in several physiological processes. Therefore, blocking CGRP may pose a risk in subjects with comorbidities such as cardiovascular disease. In addition, long-term effects are still unknown. So, as CGRP receptors are present in most of the body tissues, we still don't know in chronic stage, in chronic usage, what will be the implications of CGRP usage. And we really don't know what will be the implications in patients who have other comorbidities like cardiovascular diseases. Other consideration is with 4 different antibodies available targeting the CGRP pathway, it will be difficult to determine whether unique patient populations will have a response to a specific drug or whether one agent is superior to others. These drugs may find a specific role in the treatment of patients who have migraines that are refractory to treatment or who are severely disabled by headaches. It will also be important to determine whether the beneficial effects are sustained after discontinuation of the treatment or whether continued treatment will be necessary. So we don't have data on all these aspects. Administration of the newly developed monoclonal antibodies is either intravenous or subcutaneous. So this however, the monthly administration, which is feasible due to the long half-lives of the medication, could improve adherence and compliance to medication. The CGR. As I mentioned, CGR many body tissues, so you may get many side effects depending on the time duration you use the treatment. So I'm going to go into I'm not going to read the list, but there are various side effects you may get from CGR data at the moment. So most of the monoclonal antibodies are subcutaneous administrations, but only eptinezumab is intravenously administered. So most of them have roughly around 1 month half, so you can use them monthly. And the scientists forecast that CGRP will dominate migraine 26. So as far as we are concerned, Sri Lankans concerned, this CGRP antagonists are not still introduced into our market and the health system, but it is a potential treatment for, I would say it's a potential treatment for chronic and disabling migraine, provided that the health system or the patient is affordable to purchase the drug.
Yeah, Dr. Dhammika will join with us for your questions, and if you have any burning questions, we can spare some time for you. Yeah, Dhammika. He's on.
Hello, Dhammika. Can you hear me? I'm Janaka. Janaka is Candy.
Dhammika, can you please unmute your phone? We can't hear you.
Hello, Dhammika, can you hear me? Hello?
Dr. Dhammika, Dhammika, can you join with your audio because we can't hear you? Okay, right. So,
Hello, Dhammika? Hello?
okay, thank you very much. We'll go for at the end of the session, we'll go for the question. So let me introduce the next speaker. He's, I think he doesn't any Janaka Piris, consultant neurologist, National Hospital, Kandy. He's going to talk on about an approach to peripheral nerve dysfunction. Sir, over to you.
Good morning, everybody. I first must thank Dr. Artikala, KSM, and the ASN for giving me this opportunity. So I thought of speaking to you on peripheral nerve dysfunction and neuropathy. In medical practice, unfortunately, they come to you with not the diagnosis of peripheral nerve disorder. They come with certain constellation of symptoms and signs. So sometimes when junior doctors are confronted with these patients, they sometimes get overwhelmed. We have to start, how far to investigate them. So if you have a system in the back of your mind, how to approach these illnesses, it's easy. Just to give a brief introduction, it's a very common disorder. Prevalence is about 2 to 7%. If you take the Sri Lankan population into account, so at the given moment, there are maybe 400 to 800,000 people suffering from these disorders. As I said, the symptoms can vary. A wide range of symptoms are there. Pain, weakness, right? So, so when the patient, as I said, when you confront a patient, how to tackle this patient. So first thing is to have these 4 things in your mind. First is establishing the diagnosis of peripheral nerve dysfunction, because most of these symptoms are very non-specific. They can occur with peripheral nerve disorders as well as due to central nervous system disorders, plus other medical like metabolic disorders, even psychological functional disorders. Then once you are confident that it's a peripheral nerve disorder, next step is to have a topographic scene during the course of next few minutes. That's a pattern of involvement. Then you resort to specialized investigations like nerve conduction, EMG, sometimes nerve biopsy occasionally. Purpose of doing the special investigation is to determine whether it's a predominantly a motor, sensor, or a mixed type of involvement, or whether it is a nerve, myelin sheath is predominantly damaged, or the axons are predominantly damaged. Then the next step is to establish temporal cause of the disease. I will just briefly touch on these topics. Now, first thing is establishing the peripheral nerve disorder. It's not sufficient. As I said, the history may be suggestive. They come with numbness, tingling, as I mentioned, weakness, pain, and various things. Then you have to use some few basic equipment in the ward. For touch sensation, ideal would be to use these monofilaments, especially in diabetic clinics, people use these.
Shall we start? There are some lectures going on. We can listen if we finish early. Janaka Sedika can on. Not all in the pool. Candy, there's a make a I'll put it. Bala, I have Sergei Kahala. Maggie computer connect the money. මේක සද්දේ ප්‍රශ්නයක් තියෙනවා කම්පියුටර් එකට කරලා මේක කනෙක්ට් මගේ ලැප්ටොප් එකේ මෙතන ලොකු සිද්ධියක් නැතුව ඇතිනේ ඔව් එහෙනම් අන්තිමට කර මගේ peripheral
limbs, it's the flexor muscles are involved. So if those things are there, you are pushed toward the diagnosis of upper motor. Now, when the patient is in front of you, if you can answer these questions, it's easy to tackle this situation. What, where, when, and what setting. What symptoms have the patient has got, and what systems are involved. I will touch on this. If the patient has positive sensory symptoms, it's suggestive acquired neuropathy. This is in contrast to hereditary neuropathy. In hereditary neuropathy, positive symptoms are minimal. They don't come to you and say tingling, numbness, burning. But when you examine them, they will have a lot of signs. If you do nerve control, they will have a lot of features. Now, with the predominant thing is pain, especially burning pain. That means it's a small fibers are involved, because in large fiber neuropathies, pain is not a predominant symptom. Now, when you have predominant pain, only few differential diagnoses are there. That's easy. Now, common causes are toxic substances, especially in our in country, alcohol and associated nutritional deficiencies. Then diabetes is a very common condition that can give rise to small fiber neuropathies. Then vasculitic conditions. It's ischemic. In fact, when the vasa nervorum is involved with ischemic damage to nerves, you get significant pain. Then amyloid neuropathy is associated with severe pain. Then this rare genetic condition called Fabry's disease for registrars. Fabry's disease can cause severe pain. At the end, therefore, however, a significant proportion you may not be able to diagnose. So you, as usual, we label it as idiopathy. So in the differential diagnosis, the pain is a predominant feature. Only few conditions you have to consider. On the other hand, if large fibers are affected, it's more, the patient may have ataxia, sensory ataxia, right? So the patient is mainly ataxic. Ataxia may be due to cerebral disease also, but if it is due to neuropathy, it's likely to be as a large fiber neuropathy. So this is what, then negative neuropathic symptoms also people can have, that is loss of sensation, imbalance. So when you examine, they have a loss of sensation, absent joint position sense, vibration sense, right? These are negative symptoms, not positive thing. So proprioceptive loss can lead to loss of balance, activity. When they wash their face, it's called wash basins, and they tend to fall to the wash basin because they temporarily close their eyes when we wash our faces. Then if a person has a disproportionate ataxia, now when you examine this patient's limbs, there may be mild symptoms on neuropathy features, signs, but is out of proportion ataxic. In that situation, you have to ganglionitis. It's mainly the dorsal root ganglions are affected. It's called ganglionopathy, or these posterior columns of the spinal cord are involved. You know this few conditions, B12 deficiency, syphilis. You can come to this ganglionopathy later. Then there's a rare condition called chronic inflammatory sensory polyradiculopathy. Now, if the motor symptoms are predominant, of course, the motor symptoms, what you get is foot drop, fine. Now, if your hand muscles are involved, you may have difficulty in performance, fine motor skills. If the proximal muscles are predominantly affected, they may have difficulty using hands above their heads. And often these symptoms are combined with sensory symptoms. I will use this opportunity to mention few neuropathies where the motor component is predominant. Now, generally, often most neuropathies, sensory is predominant. But there's a few situations where motor may be predominant. One is motor neuron disease. Of course, it's not a, we call it a neuronopathy. Anterior horn is affected, anterior horn cells are affected. And this uncommon is not uncommon, condition called multifocal motor neuropathy, where you get patchy involvement of nerves in the bodies, like mononeuritis multiplex, but sensory is not. Other thing, Guillain-Barré CIDP, chronic form of Guillain-Barré, can be predominantly motor. Then you may have heard lead intoxication, acute porphyria, then hereditary neuropathies can be predominantly motor. Now, as I said, painful neuropathy, few differential diagnoses. Again, motor predominantly, few differential diagnoses are there. So if a patient comes with predominant motor weakness, you have to think of these possibilities. Then some people may have predominant autonomic symptoms, pre-syncope, syncope, diarrhea, erectile dysfunction, bladder symptoms, sweating problems. Again, you have to remember few differential diagnoses. Diabetes is one possibility. Then the amyloidosis can give rise to significant autonomic involvement. And Guillain-Barré acute, you have seen in sometimes when you put patients into Guillain-Barré into ICU, they get significant autonomic problems, heart rate fluctuation, blood pressure fluctuation. Then paraneoplastic Sjogren-associated neuropathy can have predominant autonomic symptoms. All this time I was talking about what symptoms. Now which nerves are affected? Now distribution of nerve involvement is very important in coming to a conclusion, whether it's global or distal or proximal, there's symmetric or asymmetric. Now, if you take both proximal and distal weakness globally affected, that's a hallmark of immune neuropathies like Guillain-Barré or chronic form of Guillain-Barré called CIDP. Then if it is asymmetric and proximal predominant, it's a red flag. You have to think in terms of some unusual conditions, and some of them are little serious illnesses. For example, ALS, motor neuron disease, can have asymmetrical muscle involvement. Then neuromuscular junction disorders like Lambert-Eaton, myasthenia gravis, then they can have focal or sometimes symmetric weakness also. Then this anterior horn cell disease, hereditary anterior horn cell disease called spinal muscular atrophy, can have global involvement. So often it's proximal more than distal. Myopathy is also similar. So these are pure motor syndromes. Then some certain neuropathies can have pure motor, like asymmetric or sometimes distal symmetric hereditary motor neuropathy. So that is where. Then when. Now, temporal cause of these things is very important in coming to diagnosis. If the patient has, whether the symptoms have been there for 10, 15 years, or it started 2 weeks back, again, depending on that, your differential diagnosis changes. Now, as you are aware, acute, subacute things are often immune. Guillain-Barré, vasculitic neuropathies can sometimes present acutely, the paraneoplastic conditions. Then there are other immune neuropathies. I'm not going to touch on this various odd conditions like multifocal motor neuropathy, MATSM, and various. They also can present acutely or subacutely. Now, it has been there incident for a long period. It's likely to be either hereditary neuropathy or a metabolic neuropathy, like due to diabetes, or so sometimes you can't find a cause also. Then the tempo of progression is also give you a clue. If it's a relapsing condition, again, this CIDP is a possibility, chronic inflammatory demyelinating polyneuropathy, or porphyria also can give rise to it. Now, because other conditions like diabetes, you won't get a relapsing cause. You are affected, then you are perfectly all right, then you get it again like that, right? So in what setting is also very important, that will give you an idea of the disease entity you are dealing with. Patient has been having diabetes for years, CKD for years, underlying malignancy, has been given chemotherapy, as an alcohol abuser, then those may be causally related to this. Or if there's a family history of neuropathy, it could be hereditary neuropathy, right? So what setting is also, so what, where, when and the setting. This will give. Now, often these neurology textbooks and journals dealing with teaching purposes, how to handle this situation, they combine this what and where component. Now, I will try to deal with this mixed sensory and motor pattern. Now, under that comes various distribution patterns. Then again, pure motor pattern, pure sensory pattern. To touch on this separately briefly. Now, proximal mixed sensory, both sensory and motor components are involved, asymmetric and proximal. That generally happens with polyradiculopathy or radiculoplexopathy. One of the commonest conditions people have in this country is diabetic radiculopathy. You get severe pain in the buttock region, thigh, then they get wasting of quadriceps muscles, weight loss. You have to remember this glycemic dysregulation may not be very severe. You need not have 400, 500 blood sugars for this to happen. Sometimes 140, 150, 160 blood sugars can cause this. Then other different causes are malignancy, sarcoid, vasculitis. Again, this asymmetric presentation, mixed sensory motor can happen. Then proximal and distal symmetric mixed sensory motor pattern. Again, it's suggestive of not only root neuropathy, combination of root and neuropathy, polyradicular neuropathy. Again, these immune neuropathies give rise to this picture, Guillain-Barré, chronic form of Guillain-Barré. They are generally predominantly motor, but sensories are often involved. Then again, still under mixed sensory motor, proximal and distal asymmetric. This is classical mononeuritis multiplex. You get patchy involvement nerve here, nerve there. Now, these are the causes of mononeuritis multiplex. It's vasculitic conditions, diabetes. In this country, still leprosy is a cause. I'm not going to touch on this HIV, this the immune-mediated things, MAD-SAM, hereditary neuropathy for liability to pressure palsies, lymphomas can give rise to mononeuritis multiplex. Then distal symmetric. This is the common garden neuropathy. All of you are aware. It's a length-dependent neuropathy. Often it's sensory predominant. Commonest cause in this country is diabetes. Then pure motor pattern. Now, pure motor pattern, of course, some of these are not neuropathies, but patient will not come and with a neuropathy, to diagnose a neuropathy. When they come, you have to handle these patients. It may be localized to pure motor neurons or motor nerves or neuromuscular junction or muscle. Now, if the proximal and distal symmetric myopathy is a possibility. The neuromuscular junction, generally myasthenia is asymmetric, but Lambert-Eaton can be symmetric, especially low limb involvement. Then rarely CIDP can be purely motor. Then this hereditary condition called spinal muscular atrophy, again can be proximal and distal symmetric. Then this variant of motor neuron disease called progressive muscular atrophy can be symmetric. Without bulb involvement, they can have symmetric proximal and distal involvement. Now it comes to distal, proximal and distal asymmetric innovation, asymmetric involvement, pure motor. Motor neuron disease high on the list. Then this condition, I'm not. Then such viral anterior onset disease can give rise to this picture. Then distal symmetric pure motor involvement is often due to hereditary neuropathy, so what we call Charcot-Marie-Tooth disease. But rarely distal myopathies are there. Myopathies are generally proximal, but there are distal variants. Now, when that happens, you are wondering whether it's a neuropathy or myopathy. One clue is, apart from specialized investigation, if you look for this myopathy or a neuropathy. Then distal asymmetric pure motor. Already I have mentioned this condition called multifocal motor. briefly tell you a few sentences because registrars also may be listening. It's an acquired disorder with progressive asymmetric weakness. It's due to an immune attack on the nodes of Ranvier. It's a purely motor condition. When you do this nerve conduction, you come across this thing called conduction blocks. So the neurophysiologist will give you the diagnosis. It can mimic motor neuron disease, but if this that is due to when they flex their neck posterior pressures on the spot. So internet literature, journal literature, DSMA is generally used for this condition called hereditary motor neuropathy. There are a lot of subtypes, but in a country, I don't know it, but in fact, I also use this term DSMA. That is probably by general agreement on neurology. Sometimes this Hirayama disease in this country is labeled DSMA. This is just for you to show a conduction block. When you stimulate distally, complex comes nicely. When you distal stimulate proximally, amplitude drops drastically. It's called a conduction block. Now, again, the last thing, the pure sensory pattern. When you have pure sensory pattern, it's either spinal cord sensory tracts are involved, the dorsal root is involved, dorsal root ganglia involved, or sensory nerves are involved, or small fibers are affected. Now, with the proximal and distal symmetric occurs, generally it's due to spinal cord lesions, either dorsal column or cord lesions, right? But in the dorsal column diseases, generally the pain and temperature is intact. If you have the proximal and distal asymmetric sensory pattern, generally occurs with ganglionitis, asymmetric, may if not like common neuropathies involve the distal limbs, distal part of the upper and lower limbs first, but these ganglionopathies can affect the proximal part of the body initially also. Often they have severe ataxia, they are unable to walk, sometimes paraneoplastic, sometimes the Sjogren associated, certain cisplatin associated chemotherapeutic agents can give rise to this. Pyridoxine toxicity can give rise to this. HIV, again, significant proportion, you may not be able to find a cause. Then distal symmetric, again, it's a common thing. Diabetes, as I mentioned, toxic metabolic causes can cause. So subset of this is this painful small fiber neuropathy. I got this chart. I don't know if we can print out for you. I got this from Neurology Continuum. This is a basic summary of this pattern recognition pattern of neuropathy. So sensory motor neuropathy is motor neuropathy, sensory neuropathy in upper border. Then the one side proximal and distal. Inside the box, symmetric, as I have mentioned few. I don't have time to now, already I have described those entities. Now, once this diagnosis, clinical part is over, you may resort to specialized investigations. Basic things are often involved depending on your clinical suspicion. Few things to note in the blood investigation. These pre-diabetic states, impaired fasting glucose or impaired glucose tolerance, whether they are definitively causally related to neuropathy is little suspicious. But they may be because sometimes you can't find a cause apart from these impaired glucose things. The another thing is the serum protein electrophoresis. The level of monoclonal, amount of monoclonal, protein is often, it's important in diagnosing malignancies. Because if there are low levels, oncologists will not take it as seriously. But in neuropathies, even low levels may be causally related. So because of that, now they recommend immunofixation rather than serum protein electrophoresis in diagnosing monoclonal conditions with neuropathy. And again, a few mistakes we make in when we do lumbar puncture. We do lumbar punctures in neuropathy, especially in condition like Guillain-Barré, CIDP. You look for albuminocytological dissociation. That basically what means is proteins are raised, but cells are not raised. But these cells can be go up even up to 50. That is compatible with albuminocytological dissociation. Don't go with the idea you don't get a single white cell in CSF, right? On the other hand, you have to remember in about 10 to 12% of people with Guillain-Barré, CSF will be normal. That will not exclude Guillain-Barré. Now, primary use of doing CSF studies in Guillain-Barré and similar condition is to exclude malignancies, because sometimes malignant cell infiltration can give rise to polyradiculopathy, which may mimic Guillain-Barré. Another thing is infection, especially HIV. During the seroconversion phase, you may get a condition like Guillain-Barré. So if you see a lot of white cells in CSF, you have to think twice of your diagnosis. Now, in CIDP, you have to, the cutoff level of high protein is little higher than in Guillain-Barré, because if you go by this 50 level protein, you may overdiagnose the CIDP. So this about, if it is more than 60, it's significant. Then the other thing is electrodiagnostic testing. That is also useful, although the neuropathy is a clinical diagnosis. In a few things are important. One thing is once you are not very sure diagnosis, nerve conduction will confirm your diagnosis. And other useful thing is to differentiate whether it's a demyelinating neuropathy or an axonal neuropathy, because clinically it's very difficult to confidently differentiate this. Other thing is, now you think it's a symmetrical neuropathy clinically, but when you do the nerve conduction, you find it's not so. Nerves are patchily affected in an asymmetric manner. So then again, your differential diagnosis changes. I want to mention that also because a lot of this upper limb sensory symptoms are referred to neurophysiology. They are overburdened with it. In diagnosing radiculopathy with sensory predominance, nerve conduction EMGs are very insensitive unless there's a motor component. So if the nerve conduction comes as normal with radicular symptoms with predominant sensory, don't go with the idea it's not a radiculopathy. And the other thing is you have to remember in our standard nerve conduction testing, small fibers cannot be tested. For that, there are special techniques generally not done in this country also. So in small fiber neuropathy, nerve conduction can be perfectly normal. So if the patient don't think that patient is psychological because the nerve conduction is normal, right? Then sometimes the imaging is also important. In West, we of course don't do because of scarcity of MRI facilities. Sometimes if you are not very sure, this condition like CIDP, MRI is useful because you see enhancing nerve roots in the MRI. Then this, as I said, the Hirayama disease, where you get asymmetrical distal upper limb weakness, it's useful to diagnose it. Increase in ultrasound is also used to diagnose compressive neuropathies like carpal tunnel, cubital tunnel compression. Then when to consider nerve biopsy. Nerve biopsy is also not necessary. It's not very useful, but it's not. You should not do it at a routine procedure. Only few these conditions you can diagnose. If you are suspecting a vasculitic neuropathy, it's useful. Then if you suspect sarcoidosis in neuropathy, is useful. In leprosy, amyloidosis, these are the things are I think nerve biopsy has a place, not in each and every patient with neuropathy. Then for as I earlier also said, the small fiber neuropathy is difficult to diagnose by nerve conduction. In the situation, again, this is not done in this country. Skin biopsy with special staining techniques is useful in diagnosis. So that is basically the approach to neuropathy. This pattern recognition pattern, topographical distribution. If you have that in the back of your mind when a patient sits in front of you, it's easy to tackle the situation, to avoid mistakes. Thank you.
Thank you very much, Dr. Janaka. There is one question is diabetes mellitus, is it global peripheral neuropathy? In diabetes mellitus.
Is it a global neuropathy?
Yeah.
No, it's generally not. It's a distal symmetrical dying back process, length-dependent process. It's generally predominantly sensory neuropathy. It's a distal links are affected. Now, in length-dependent neuropathies, it generally start with longest nerves, like so it's in toes. So it gradually spread up. It when you start getting symptoms around your knee level, they start developing symptoms in hands also. If there's in a diabetic patient comes with predominantly motor, you have to think twice. Later on, of course, they can get motor involvement. It's not a global neuropathy, but of course, advanced stages, it could involve the proximal parts of it.
Questions? Thank you very much, Dr. Janaka. Actually, I'm happy to see that senior neurologist from Kandy is here today. And actually, I mean, they are very active sort of participants in the Kandy Society of Medicine as well. Although Dr. Janaka is representing the Association of Sri Lankan Neurologists today. So thank you very much for that. And then next we have Dr. Dhammika Halakone is there. There was a question to be directed to him.
Hello, Dhammika. Can you hear me?
Good morning, sir.
Good morning. I'm Janaka Pires Kandy. Nice presentation. I was listening to your talk. Small question now, this CGRP antibodies, are there studies, because I'm always little paranoid about these pharmaceutical companies. Have they done this head-to-head control with drugs like topiramate? Of course, they have done placebo-controlled trials to see that these CGRP antibodies are more efficacious than well-established drugs like propanol, topiramate, and various things.
No, sir. They have now. I have shown you the Evolve 1 and Evolve 2. They have. I mean, they have done. They have tested individual monoclonal antibodies, but not done head-to-head studies up to now. But they have done comparative studies with topiramate. Why they have chosen topiramate is a class 1A recognized treatment for migraine. We don't have that much strong data with the propanolol and the other kind of medicine, but the topiramate, we have strong evidence that it can be used for use as a prophylactic treatment. So they have done comparative studies with topiramate, but not head-to-head studies directly, sir.
Thank you.
Okay, thank you, sir.
Thank you very much, Dr. Dhammika Halakone. In the absence of any more questions, I would like to introduce the next speaker. I mean, there's a very brief introduction. He didn't want any elaborative introductions. Dr. Indunil Vijayveera is a senior consultant neurologist from National Hospital Kandy, and he will speak about diagnosis and management of Parkinson's disease. Over to you, Dr. Indunil.
Good morning, everybody. Can you hear me? Yes. Thank you, Professor Manjula and the KSM crowd for giving me the opportunity to come here to participate in this symposium. Going to look at a few things about the Parkinson's management, the current thoughts. Next few minutes, I will just briefly go through the diagnostic profile and the various stages of the disease which are important for us to identify, and management of motor symptoms as well as non-motor symptoms, And finally, the management of motor complications and the advanced state of Parkinson's disease. Parkinson's disease is a constellation of symptoms and signs. Now, these are, you all are very well versed in this. There are marks, faces to posture, forward tilt, hand tremors, and short step gait, tremors, hands and legs. So it's a constellation of common symptoms and signs, as we all are well aware of. It's a multi-system disease. Now it has its effects on the brain, the eyes, the gut, the skin, and the respiratory system, heart, and the autonomic system. So it's basically a multi-system disease. Now in extreme conditions, you will see this extreme flexion deformity of the thoracolumbar trunk, which is called the camptocomia, on a flat plate. Exact cause of this is still not very certain. Other interesting sign is the lateral bending of the trunk, as seen in a Pisa sign, like a leaning tower of Pisa in Italy. Furthermore, another interesting sign is a striatal toe, where you get the extension or dorsiflexion of the toe. It can be painful. Sometimes you can get the same thing in the thumb as well. So it's important for you to look at these things. Otherwise, these signs will be missed in patients. Now, the first instance where some sort of criteria were designed to diagnose Parkinson's was the UK brain-branch criteria. The essential feature was bradykinesia, that's slowness of movement, and there is reduction in the amplitude and the speed of repetitive actions, which should be followed by at least one of the following: rigidity, the rest tremor, and the postural instability. So these are the very first set of criteria developed by the UK Parkinson disease brain bank. And there were some exclusion criteria to rule out any secondary causes like Parkinson features. We will deal with these things in detail in a little while shortly. And there were some supportive criteria as well, just like unilateral onset, excellent response to L-DOPA, and severe L-DOPA-induced chorea, etc. Then the Movement Disorder Society developed a set of diagnostic criteria in 2015, which looks at the features more extensively. So there you need exclusion. There again, the essential criterion was bradykinesia or tremor. There was some absolute exclusion criteria. You have to exclude all these criteria to exclude a secondary cause. And there were some red flags. There should not be any red flags. And there were some supportive criteria, something similar to UK brain-branch criteria. We'll look at these things in more detail now. First, you screen for Parkinson's. That is, you look for the patient with bradykinesia and tremor or rigidity. And then you look for screen for exclusion criteria. Mind you, you might, in the initial phases of Parkinson's, you might not get these classical features. So this could be a prodromal phase still. So it's important for you to, if the patient is symptomatic, to examine the patients after some time. Okay, so you exclude the exclusion criteria and then look for red flags. If there are no red flags, you look for supportive criteria to diagnose the definite Parkinson's disease. So what are the absolute exclusion criteria? Unequivocal cerebral abnormality that you would get in things like multiple system atrophy and other cases of brainstem involvement. Other important supranuclear gaze palsy. Now you have to remember, you can get upward supranuclear Gales, vertical supranuclear Gales palsy in normal old age or Parkinson's disease patients. Now, if you see downward vertical Gales palsy, that is more in favor of a supranuclear palsy. Then behavioral variant front temporal dementia or primary progressive aphasia. Now, that's another important condition which might masquerade as Parkinson's disease. They can be slow in movement, hypophonia, and their mental abilities can deteriorate fairly quickly, and they get aphasic fairly soon. So that's another thing you have to think. If the Parkinson's features are restricted to lower limbs for more than 3 years, that's more in favor of a very likely vascular Parkinson's disease. And if there's no response to high dose levodopa, that's another exclusion criteria. Cortical sensory loss, limbic ideomotor apraxia, and progressive aphasia, these are features of corticobasal degeneration. A normal functional neuroimaging of the presynaptic dopaminergic system. I will deal with in this little while later. And documentation of any other condition which can produce Parkinsonism. The red progression of gait impairment requiring wheelchair use within 5 years. That's not likely to be of Parkinson's disease. Then absence of progressive motor symptoms and signs over 5 years. Early bulbar dysfunction, that is again with dysphonia, dysarthria, more in favor of a alternative condition. Inspiratory respiratory dysfunction, inspiratory stridor, is not seen in Parkinson's disease. Severe autonomic failure, although it is seen in Parkinson's disease, if you see severe autonomic failure, early onset, that is very unlikely to be Parkinson's disease, syndrome, like multiple system atrophy. Recurrent falls early on, again, unlikely to be Parkinson's disease. Dystonia, contractures of hands and feet, that is more in favor of a corticobasal degeneration other than Parkinson's disease. An absence of non-motor features, common is again unlikely to be of Parkinson's disease. Tract signs, again, that you don't see in Parkinson's disease. Supportive criteria we have already discussed. Levodopa induced dyskinesias, clear response to levodopa. And olfactory loss. Why olfactory loss? Now, alpha-synuclein neurodegeneration is thought to start in the olfactory bulb. So that is why you see patients coming with anosmia, although it's very difficult to get this history from our patients. Or cardiac sympathetic denervation. Why cardiac sympathetic denervation? Now, this occurs in preganglionic and postganglionic autonomic nerves. And in Parkinson's disease, it occurs in preganglionic as well as postganglionic. And multiple system atrophy, usually they have been preganglionic. So because of this, if you see if you inject methiodobenzyl guanidine to these patients, you will see a reduced uptake in Parkinson's patients. Whereas in MSA, it's usually normal. So that's why they have given it as a supportive criteria. Now we talked about the scan, just to look at the activity of the striatum. Now here you inject a radiopharmaceutical injection, which detects the activity of the dopamine transporter. Now, dopamine transporter is involved in the reuptake of dopamine in the striatum. If now this is monitored by the gamma camera in the SPECT, single photon imaging field tomography. So this is the normal activity is on your left side, the comma-shaped activity in the striatum. If the dopamine transport activity is less, you will see this square-shaped activity. in a patient. Now, the most important use of this is to differentiate patients with essential tremor from Parkinson's patients. Because all the other Parkinson's syndromes might give the same result. So you can't differentiate one from the other. So differentiation of essential tremor from Parkinson's disease, you can use this. Now, what are the stages of the disease? Now, I said there can be a prodromal phase or preclinical phase. Any motor features of Parkinson's disease. They might get non-motor features like REM sleep behavioral disorders, depression, constipation, anosmia, mild autonomic disturbances. They will not have any motor symptoms. Then they start getting the motor symptoms and the diagnosis is made and the dopamine therapy is started. After some time, you do the maintenance therapy, they are doing quite well, reasonably happy. And then they develop motor fluctuations, dyskinesias, cognitive impairment, worsening of autonomic disturbance like urinary symptoms, postural hypertension, etc. Then gait disorders they develop, freezing, repeated falls, etc. And that's the time they get into advanced state. And there you might need, furthermore, there are executive functions also deteriorate with dementia, etc., psychosis, etc., and drug-induced problems as well. And that's the time of advanced Parkinson's disease. They might need palliative care after that. So the temporal profile of the disease. You have to be aware of these stages of the disease. Now let's look at the non-motor features. Now autonomic features are blood pressure variations, tachycardia, urinary disturbances, sexual dysfunctions, paroxysmal sweating, mydriasis, dilatation of pupil, halo, etc. So this paroxysmal sweating, some of these patients complain of this paroxysmal sweating. So you have to be careful or intelligent enough to pick this up early. Gastrointestinal. Why gastrointestinal? Because as I told you, alpha-synuclein pathology occurs in the gastrointestinal tract as well. So therefore, the liver drooling of saliva, ageusia, the lack of taste, that is constipation, fecal incontinence, eructation. What is eructation? Emission of air through the mouth. And meteorism, that is collection of air in the tummy, abdominal fullness, that they complain. Then they get REM sleep behavioral disorders, excessive daytime sleepiness, vivid dreams, etc., and period limb movements, restless leg syndrome, etc. We will discuss this in a little while. The neuropsychiatric, they get depression, panic attacks, dementia, hallucinations, etc., etc. And impulse control disorders, mainly with medication, dopamine dysregulation syndromes, and dopamine agonist withdrawal syndromes. They get some sensory pain, olfactory disturbance, etc., and fatigue, etc. These are the important non-motor symptoms of Parkinson's disease that you got to identify. Then how do you assess these patients? Now, you have to document it. The earliest thing was to have the Ewing and Yahr scale, where there are 5 domains: mild, moderate, and severe. And later, Unified Parkinson's Disease Rating Scale, UPDRS came, and now they have the modified MDS UPDRS scale. You can download it from the web so that you can record it and see the progression of the disease. If you look at Ewing and Yahr scale, number 1, stage 1 is unilateral involvement. Stage 2 is bilateral involvement without impairment of balance. Number 3, moderate bilateral disease with some postural instability, but they are independent. 4 is severe disabled and unassisted still. 5 is more progress. Now we look at the drug. Now, levodopa, as we all know, is the gold standard of therapy still in Parkinson's disease. Now, if you could, then dopamine agonist and MAO-B inhibitors. Activities of daily living is more sensitive or more improvement with levodopa other than the other two. Motor complications are more with long-term levodopa therapy than the other two. Adverse events are common to all. This cartoon shows this more or less same thing. Levodopa with decarboxylase inhibitor can start as initial therapy. Motor benefit is more. Dopamine agonist, pramipexole, propinerol, or roticotin skin patch that you can use once daily. Other two also available other countries as once daily skin patch. And you can use apomorphine subcutaneous pen for rescue therapy. We'll discuss this later. Then monoamine oxidase inhibitors, selegiline, rasiligilene, and safinamide, Niva1. Again, you can use it once daily, but their motor activity is less. COMT inhibitors, entacapone, you can use as adjunctive therapy. Give another dose, it starts again, comes down again. So green wave shows the on period, upwards, and downwards it shows the off period. Now here in a normal patient, you can start rescue medication for these varying of periods, like subcutaneous apomorphine or inhaled levodopa, or you can give increased dose of L-dopa. Yeah, so that's the apomorphine pill. Now, before starting on this apomorphine, you have to give an apomorphine challenge to the patient. You have to admit the patient. Before that, you have to load him with demperidone and do a ECG to look at the QT interval. And then you give testing doses 1 milligram, 2 milligram, 3 milligram every 45 minutes and look for response for about 20-25 minutes. So up to 7 milligrams, you can give like this. If they are not responding up to 7 milligrams, that means they are not responding to apomorphine. Then you can titrate the dose and get the patient on the apogo pen. Or you can start on inhaled levodopa. It's like the inhalation for bronchial asthma. You insert the capsule to this and it punctures and then you inhale 2 capsules at each go. So these two, they say it acts within about 10 minutes. So if you are walking and you get stuck somewhere, you can either use Invija or apomorphine, apogopin to get the boost required. And if the patients develop tremor, you can counteract with anticholinergics. Amantadine is usually given when the patients give dyskinesias. It may release dopamine and norepinephrine from storage sites or inhibit reuptake of dopamine and norepinephrine. Usual dose is 100 milligrams per day or 100 BD2 3 times a day. Now, adjuvant therapy, if a patient develops motor fluctuations in optimal levodopa therapy, you can offer dopamine agonists, COMT inhibitors, and MAO inhibitors rather than further increasing L-dopa, because that will cause further motor fluctuations. So you have to titrate this very carefully. Now let's look at non-motor symptoms. Now, impulse control disorders. Now, these are very common with when patients start using dopa agonists, like compulsive gambling, compulsive shopping, binge eating, hypersexuality, funding. That's a repetitive motor behavior. Right. Or something like that. Some patient might start counting the tiles on the floor, or he might pull things from a drawer and rearrange it, again pull it, rearrange it without any objective. He keeps on doing the same repetitive movement. That's called funding. Management, you have to reduce the dopamine agonist and reduce the L-dopa dose, and cognitive behavioral therapy. So it's very important to identify this and to provide appropriate care for these patients. What is dopamine dysregulation syndrome? They get addicted to dopamine. So in addition to whatever their usual doses, they don't have motor requirement, but they keep on taking additional doses. That's called dopamine dysregulation syndrome. Now again, when they do it, they develop motor fluctuations, compulsive disorders, etc. because of the high dopa level. So it's a vicious cycle. Daytime sleepiness. Now, even without L-dopa, you all get into this one point in time. Right. Now, why do they get daytime sleepiness? Because they develop nocturnal akathisia. So, nighttime, they can't move. Because of this, they get up. Or they develop periodic limb movement. Again, the sleep is disturbed. Or restlessness syndrome, the unpleasant feeling in the legs. Again, they are sleep is disturbed. And could be due to medication also. So all this has to be excluded. And if you really want, you can start on modafinil. REM sleep behavior disorders. Now, REM sleep is the time where you lose your muscle tone. But in this case, they do not lose muscle tone. In fact, they start acting the dreams. So they are living in it and acting. So that's why they start kicking, punching, biting, jumping out of the bed or strangling the bed partner, etc. So it's a very worrisome symptom. Diagnosis to the careful history, and you can do the polysomnography and diagnose this. Maybe behavioral therapy, creation of safe sleep environment, padded bedside furniture, or putting a mattress low down, advising the partners to sleep on separate beds, etc. Clonazepam is found to be effective in these patients to a certain extent, and melatonin. So this is very important for you to identify. Now, restless leg syndrome. They get the urge to move the legs, very unpleasant, creeping, crawling feeling in the legs. This is not the only condition where you get this restless leg syndrome. In anemia, diabetes, pregnancy, all this, or other peripheral neuropathies also. It's important for you to exclude all these conditions and come to a conclusion. Again, dopamine therapy is advised for this type of patients. and periodic limb movement. Now here they get sudden jerking of the legs. Usually the knees flexed and dorsiflexion at the ankle. Even the arms can be affected, but usually leg. So every now and then this happens, lasts for about a couple of seconds. And within an hour, you can get about 15 times this happening. So invariably their sleep is disturbed. And their bed partner sleep is also disturbed. So periodic limb movement. Nocturnal akinesia. This is when I told you earlier. So nighttime modified or long-acting levodopa or dopamine agonist might be useful, or a roticotin patch, long-term dopamine agonist patch might be helpful in this type of patients. Orthostatic hypotension is important for us to relieve the medication. It can be antihypertensive, including diuretics causing this problem, and dopaminergics, anticholinergics, antidepressants, all can cause this problem. So we have to take appropriate measures. If failing that, might try fludrocortisone. Dementia. So this is another thing where the Lewy bodies come into play. You can use cholinesterase inhibitors or NMDA receptor blockers. So this, of course, is a late phenomenon in Parkinson's. Hallucinations and delusions, depression, insomnia, all can be caused with Parkinson's disease. So these are important non-motor symptoms you got to elicit from the patient. They might not come forward with this unless you specifically ask these things. Drooling of saliva. It's another problem. Constipation. Erectile dysfunction. You can use sildenafil. Okay. Now, once you start treating the patient, you have to consider these things. You have to ask the patient, are your symptoms sufficiently controlled? Right? If not, the answer is no. You can either increase the dopamine agonist or increase the individual levodopa dose. Then when you wake up in the morning, is your mobility acceptable? That is morning. As soon as they get up from the bed, are they able to get down from the bed and walk? If the answer is no, that's off time in the morning. So immediately after waking, you can prescribe levodopa dose. Or evening dopa agonist dose or levodopa dose, you can increase. When your medication starts working, does the effect last until the next dose? That is, you trying to find out whether the wearing off has started. If that's the case, you can increase the dopamine agonist dose, or you can give more frequent L-dopa, or add COMT inhibitor or MAO-B inhibitor to the existing L-dopa dose to try and get this wearing off sorted. The other thing is, does the effect of some of your doses take long to start, or do you completely fail to experience its effects? That is delayed on or failed on. Sometimes when even if you give the L-dopa, they don't start working. That's the failed on. Or when you give the dose, it takes a longer time to start working. That's the delayed on. So this usually happens with the poor gastric emptying in late stages of Parkinson's disease. Therefore, in such patients, you can give L-dopa 30 to 45 minutes either before or after the dose, after the meal. Early phases is not very important, but once the patient develops this stage, it's very important for you to ask this and advise the patient to take the L-dopa 30 to 45 minutes before or after the meal. Or you can give prokinetics and exclude Helicobacter infections and small bowel inflammatory disorders. They increase the bacterial growth in the small bowel because of the lack of motility. Then you have to look for dyskinesia. Do you have excessive involuntary movements when your medication starts working? That is dyskinesia. If you find this, you give lower dose of L-dopa and more frequently. You give lower doses more frequently, and you can add amantadine. Is your mobility during night acceptable? That's a nighttime off. prescribe immediate release levodopa for nighttime wake-ups. Immediate release, you can give immediate release L-dopa when they wake up in the night. Or evening dopa agonist, you can go up. It's important to look at these problems of the patient. Physiotherapy and physical activity, patients with early disease, and for patients with balance issues. We'll look at a small brief video.
Today we started what I hope to be an ongoing program called Dancing with Parkinson's. And it is a program where people with Parkinson's, their caregivers, the community come together, led by a very trained and qualified group of dance instructors and a pianist. We do a lot of movement, a lot of big body movement, a lot of dance. The exercises gives them life and joy and excitement that some of them have not had about areas of their life.
Right. Now, speech and language therapy for patients with speech problems, swallowing or saliva-related problems. Now, there's a thing called Lee-Silverman speech therapy. This different protocol where they're shown very good responses with this type of Parkinson's patients. And nutrition is very important now because the proteins are competing with the L-dopa for absorption. We must not avoid the total protein consumption. We must not avoid it. We must give a normal total protein amount. But you try and give most of the proteins in the final meal of the day, because when they interact with the L-dopa effects goes down. So you combine it because nighttime they generally sleep. So give them final meal the maximum amount of proteins. And vitamin D supplementation is also important. Okay. Now, how do we know that the patient is going into advanced state? Now, motor features, troublesome level of motor fluctuations, until 1 hour, more than 1 hour of dyskinesia, more than at least 2 hours of off time, dystonia with pain, they develop freezing movement, you need multiple oral doses of levodopa. That's if your frequency is more than 3 hours or less than 3 hours, that's not going to work. So that means they are in the advanced state. You can give L-dopa every 3 hours. If they are still not benefited, that means they are in the advanced state. That's not going to help. Further increase is not going to help. Non-motor fluctuations, impulse control disorders, needing help with activity. All these are features which tells you this patient is going into the advanced state. Now, what can we do for the advanced state? For motor fluctuations, you reduce the L-dopa dose and add dopamine agonist and COMT inhibitors. For MAO-B inhibitors, you can give small, more frequent dose of L-dopa. It is thought that these motor fluctuations are mainly due to pulsatile stimulation of the dopa receptors. As you give, say, 3 times or 4 times a day, you give pulsatile increase in the doses. So have a general less pulsatile stimulation. You try and give small doses more frequently. That's the idea. Switching from immediate release to control release form or continuous intrajejunal duodopa. Do endoscope, you introduce into jejunum, you give a levodopa gel, duodopa, for the advanced disease. Or you can give subcutaneous infusion of apomorphine. Again, you have to subject the patient to the apomorphine challenge, and then if they're successful, you can start on this for this advanced state of Parkinson's patients. Let's look at dyskinesia. Coriform movements of the hands and legs, and maybe the
It's
Pains
much
and
more
the
recent
neck
than
area.
that. It's been particularly bad the last 4 or 5 months.
Classic dyskinesia.
Before that, it was
So in such patients, you can give immediate release form, also more consistent and predictable dosing cycle, as I told you earlier. Or you can use intrajejunal dopa, add inhibitors, or lower the lower levodopa dose and add dopamine agonist, titrate it, balance it, and give amantadine. It's quite a useful drug in this situation. This kind of, and surgery, symptoms, and tremor will respond to deep brain stimulation. But freezing, postural instability may not well respond to deep brain stimulation. You put electrodes in the substance nigra and connect a pacemaker and increase the frequency to counteract these features. The patient might be able to come down a little on the L-dopa doses. Again, this is limited for advanced state of Parkinson's disease. What is freezing? No. They get this when they come to an obstacle, or when they turn, or when they want to climb a stair. See, tremulous of the legs, turning is difficult. The feet are glued to the leg, the floor, and now they start walking. That's freezing. So how to tackle this? This might not respond to DBS even. Now you can give visual or auditory cues. Now this walking stick has a laser light. When it pointed to the ground, it emanates a beam. So you get a target, goal there. The patient can lift the leg and put it there. Or simply you ask the patient to lift the leg and put it, like marching, if they freeze. And this laser shoes do the same thing. The laser beam, it is projected forward. So patient puts the legs and walks past that. So you give visual and auditory, you can get a sound or something like that. So visual and auditory cues might help in this patients with freezing. Now, are there any disease-modifying drugs? Not the study in data talk way back in 2000, early 2000, I think. And it has shown some benefit in delaying the progress of the disease. But fairly recently, Adgio and Tempo studies, Adgio studied about 1,000 patients where they had given single dose Azilect, prazogeline, for patients who are not treated. So that's early Parkinson's disease patients. And Tempo studies studied about 400 patients. And there the information was they do delay the progress of the disease. But these are very small studies. Further studies are required to come to a definite conclusion. So the message is at the moment, there are no disease-modifying drugs for Parkinson's disease. Stem cell transplantation, but there are some studies going on at the moment in states and other countries. They are transplanting pluripotent stem cells in the putamen or the striatum to try and see that whether that will help the Parkinson's patients. But up to now, this is not a validated method of treatment, but there are still studies going on. A lot of people are involved in this. In summary, Parkinson's is a common neurodegenerative disorder. Actually, it is the second commonest neurodegenerative disorder behind Alzheimer's disease. So therefore, early recognition is important look out for non-motor symptoms for early recognition, because it could be still the prodromal phase. Once diagnosed, if the diagnosis is correct, they do show very good response to L-DOPA. If not adequately controlled, always review the diagnosis to exclude the other possibilities. Review at least once in 6 months. Look out for medication-induced problems, early referral to physiotherapy and occupational therapy, of course, multidisciplinary action. And advanced disease, you have to recognize early and provide appropriate management of their symptoms as much as possible. Thank you very much.
Open for questions. There are no online sort of posted questions.
Thank you very much. It's a very comprehensive speech on half an hour. What are the practical issues I come across as a practitioner clinician is now sometimes people are referred to us or they themselves not antipsychotics, neuroleptic with Parkinsonian features. I wonder whether this person with Parkinson's disease was brought on by these drugs, as evidenced by the fact that they're very asymmetrical bradykinesia, asymmetrical tremor. So I wonder now we can't start L-DOPA or we can't stop the antipsychotic. There is a dilemma. How do you tackle this situation?
I think you are absolutely correct, Janaka. If they have predominantly asymmetric features, very likely they are diseases brought on by this thing or precipitated rather, but they have background illness. So in such cases, I think there's no harm in starting because we don't have to that scan. So if you do that scan, you can straight away say where you stand. But in such situation, I think you are correct. You can theoretically start. So symmetry and asymmetry.
So thank you very much, Dr. for that very informative lecture. Now we will break for tea for a short while. We'll be starting in 15 minutes. That is 10:40. Yes. The following lecture will be by Dr. Sajda Veerasinghe after the tea. Thank you.
Mandar.
මම ස්ක්‍රීන් එක පේනවනේ රයිට් මට ඔගේ පැත්තේ නම් මොකුත් පේන්නේ අවුලක් නැහැ නේ මට මාව පේන්නේ නැහැ තව මට දැන් නම් මාව පේනවා පේනවනේ හරි මේ පොඩින මම එහෙනම් මේකෙන් කතා කරන්න එහෙනම් දිග බලන්න මේ Zoom එකේ හරි අයින් කරගන්න අදර ඇහෙනවද මට කැඩි කැඩි වගේ තමයි ඇහෙන්නේ මාව ක්ලියර්ට ඇහෙනවද දන්නේ නැහැ මට ඇහෙනවද මාව මගේ නම් කනෙක්ෂන් එක නම් හොඳයි මට ඔයාව නම් ඇහෙන්නේ නැහැ හරියට ක්ලියර්ව
දැන් ඇහෙනවද
තාම හොඳට ක්ලියර් නැහැ ටිකක් කැඩි කැඩි ඇහෙන්නේ මාව ඇහෙනවනම් ප්‍රශ්නයක් නැහැ මට හිතෙන්නේ
දැන් ඇහෙනවද මාව
ඔව් ටිකක් මම හිතන්නේ පොඩි කො එකක් යනවා හැබැයි මට ඇහෙනවා දැන් ඇහෙනවා
ඔයා හොඳට ඇහෙනවා
මම හොඳට ඇහෙනවා නේ රයිට්
ඕකේ හරි මල්ලි
හරි රයිට් ඕකේ එහෙනම් මෙහෙම තියන්න මම ස්ක්‍රීන් එක නේ Teknis kan pagi nih.
Yes, welcome back to the second part of the session. Let me introduce Dr. Sajith Veerasinghe, consultant neurologist at Teaching Hospital, Anuradhapura. He's going to talk about the COVID-19 and acute ischemic stroke. Over to you, Sajith.
Thank you, sir. Thank you very much for the kind words of introduction. Since the latter part of 2019, we've been hampered by the COVID-19 infection, and that is having a significant impact on our social life and also on the medical practice. So in today's the neurology course, we thought of discussing about how the COVID-19 is going to affect the neurology, especially the acute ischemic stroke management. So what I'm going to discuss today in the next 20 to 25 minutes. I thought I'll just touch upon a little bit about the neurological complications of COVID-19 and a little bit about figures and the numbers, without which our talk would be incomplete. And then we'll jump into stroke and the management mechanisms and the controversies about the vaccination and the stroke. So why do we talk about neurological complication of COVID-19 today? Now, if you look at the numbers, the significant complications following COVID infection, the neurological complications is not quite common. But if you look at the magnitude of the pandemic, now by 28th, that's just 2 days ago, in world, it was 262 million cases. So it's a huge number of cases are there. Therefore, even a disease with the smaller proportion of or the smaller percentage of complications, we are going to see large number of cases. So that's the reason why we are going to talk about the neurological complications of COVID-19 today in our neurology update. So how is the nervous system is affected by COVID-19? The first thing would be the direct effect of the virus on the nervous system. But when scientists looked into this, the hypothesis, they found in the postmortem studies, they couldn't find much viral particles in the brain itself. So the virus is not very neurotrophic virus. Therefore, the direct effect of the virus causing nerve damage is not very common. Then why the nervous system is affected? So then comes the second hypothesis, that is the immune-mediated mechanisms, which could be para-infectious or post-infectious. The para-infectious is the neurological complications which comes during the infection process, usually in the first week or two. And the post-infectious is which usually comes 3 to 4 weeks after the acute infection with the COVID-19. And there's a lot of evidence coming up about these are due to immune-mediated, also due to small vessel, the microvascular disease causing the complications rather than direct invasion of the nervous system by the virus. And the third thing would be neurological complications due to systemic effect of the COVID-19. For example, if the patient has a respiratory failure or cardiac failure, then secondary to that, the patient could develop neurological complications. So what are the significant neurological complications that we come across? Stroke, meningitis, encephalitis. The true encephalitis with the virus is not common, but the encephalopathy due to this microvascular involvement is quite common in the severe disease. Myelitis, that is inflammation of the spinal cord, and the central nervous system vasculitis, especially small vessel disease, and ADA, that is acute disseminated encephalomyelitis or its hemorrhagic variant, and acute neuropathies such as AIDP or the Guillain-Barré syndrome. And also there are a large number of mononeuropathies or the mononeuritis multiplex associated with the COVID-19 as well. So these are the serious or the significant neurological complications. Other than that, there's a large number of patients with neurological presentations, maybe headaches, generalized body aches, malaise, or chronic fatigue syndrome after the once acute infection is settled, or anosmia. So those are not serious complications or serious manifestations, but these are the significant neurological complications that we are worried about. Now we come to our proper topic, that is COVID-19 and the acute ischemic stroke. Right, so what do you know about the numbers and the figures? So these are the research from the hospitalized patients. There are US and the European numbers. But if you look at one of the earlier studies that is done in China, Wuhan, the early 2020, the numbers were a bit higher than this. for them, the stroke percentages was around 5%, 1 to 5%. But the numbers are quite low in the study cohort. And then there were 2 studies done in US, New York, and there's another study done in Europe. They found the numbers were around 0.4 to 2.7, the ischemic stroke. So the percentage is not that great or that much high compared to the first study. And these 2 cohorts were large numbers. So probably these numbers are better manifestation, although they show better than the first study. And what are the hemorrhagic strokes? It's about 0.2 to 0.9%. And this hemorrhagic stroke includes the primary hemorrhages and also the hemorrhagic transformation of acute ischemic strokes as well. And then the worried complication of is the cerebral venous sinus thrombosis. That is not that common. That's about 0.08%. That's done in one study. And the risk of the stroke varies according to the severity of the COVID-19 infection. So actually these numbers from the Chinese study, which I mentioned previously. In the milder disease, the prevalence of the stroke is less than 1%. But when the disease is severe, especially when the patients were in the ICUs, the numbers are high. It can go up to about 6%. And the median age of the patients was around 65 to 68 years old in the COVID-19 infected cohort, and a control population, that's about people about, the patients checked around 1 year ago, it was around 71, age 71. So there's no big difference in the median age, and that was not very significant. But there are a lot of case reports coming up regarding the young patients with ischemic strokes, and these are multi-territory stroke as well. So that's the place where the stroke mechanisms are important. Right, so what are the risk factors noted in the literature? So the first risk factor is older age. And then the vascular risk factors such as hypertension, dyslipidemia, diabetes, atrial fibrillation. So these are the common risk factors for acute ischemic stroke or any kind of vascular disorders. And then why are we worried about COVID-19 and the stroke if these are the risk factors? So is COVID-19 risk factor itself? So when the scientists looked into that, they found, actually they compared 2 cohorts. First cohort is patients with acute ischemic stroke following COVID-19 infection. And they looked at a similar kind of AIDS patch population about a year ago, kind of similar numbers. And they compared the prevalence of stroke in the 2 groups. And they found the odds ratio was 20.9 with a p-value of less than 0.001. So that's a significant, the ratios is very significant. So they found the COVID-19 per se is a risk factor for stroke. And usually stroke occurs 1 to 3 weeks after the onset of the acute COVID-19 infection. All right, so if COVID-19 is causing stroke, so how does it cause it? What are the mechanisms? So the postulated mechanisms are hypercoagulability and the pro-inflammatory state, which comes with the infection. And then the cardioembolic causes, then changes in coagulopathy and anticoagulation, some may be even iatrogenic, and then the COVID-19 vaccination associated strokes, and then the cryptogenic. I'll just touch a little bit of cryptogenic strokes later. Right, so what about the hypercoagulability and pro-inflammatory states? The virus itself or the host immune response refers to a thrombophilic condition. Now that thrombophilic condition is, you can check it by looking at the elevated markers of hypercoagulability and the inflammation. So there's one study published in Frontiers Neurology last year. They found the fibrinogen levels and the D-dimer levels, things which you can actually check in our even the hospitals here. These are the patients with the milder stroke, MRS less than 3, and the patients MRS more than 4, this patient severe stroke. The D-dimers and the fibrinogen, those are the markers of hypercoagulability, were increased. So, so we have evidence to say that hypercoagulability and inflammatory, the pro-inflammatory state is associated with this hypercoagulable state which is causing strokes. So why do they develop the hypercoagulable state? So one thing is the direct invasion of the endothelial cells by the virus that will cause endothelial dysfunction, and that result in thrombosis, if you look at the Virchow's tract. And then the complement-mediated endothelial damage, that's a membrane attack complex at C5b29, and then the changes in the circulating prothrombotic factors, that is elevated factor 8, elevated fibrinogens, circulating prothrombin thrombotic particles, and the neutrophil extracellular traps, hyperviscosity. These are the things that are associated with the hypercoagulable state, which result in increased thrombosis, which makes the blood very sticky. So how to check for these? So there are laboratory markers that we can look into. One thing is the increased fibrinogen and the D-dimers level. I showed the graph previously, it's still down the right side of the screen. And then the prolongation of the PT, the prothrombin time, and the APTT, activated partial thrombin time. Also, these patients have mild thrombocytosis or thrombocytopenia associated with the acute infection. And then there's a study looking at whether the antiphospholipid antibodies are associated with the patients who are having the thrombosis. Actually, one study showed they had increased antiphospholipid antibodies, especially anticardiolipid antibodies, but not the lupus anticoagulant or the beta-2 microglobulin. And there's one study which showed those patients had lupus anticoagulant only in the patient with prolonged APTT, but the literature is more towards the positive antiphospholipid antibodies than the lupus anticoagulants, the lupus, the anticardiolipin antibodies. That's about the hypercoagulable state. The second thing is infection. So does any acute infection causes thrombosis, which could result in stroke? Well, there's a study published in 2011. It's an older study. That is a cardiovascular health study, it's a US study, which looked at patients who are admitted with infection. So it includes just chest infection, the urine infections. So whether these patients are at increased risk of thrombosis? Yes, they found that the odds ratio was 7.3, which was significant. So I'm going to put the significant levels here. So having infection increases the thrombotic risk because of inflammation, which gives rise to prothrombotic state. So this is for general infection, generalized infection, general infections, not just the COVID. So then people look into the COVID, whether having a COVID infection per se increases the risk of stroke. What do we found there? So they found that having infection itself increases the thrombotic state. So they looked at two cohorts of patients COVID-19, numbers are almost 2,000, and the patient had influenza, that's about 1,500 patients. They compared the infection causing the thrombotic state in these two populations, the two cohorts of patients with infection, the two different infections, influenza and the COVID-19. So what they found was the cohort with COVID-19 had an increased chance of getting thrombosis and the stroke. So the COVID-19 and the COVID-19 infection, it causes increased thrombosis, which could result in stroke. So the percentages was about 1.6 to 0.2%, and it was significant, and the odds ratio is 7.6. I put the whole details here, but it's if you want, you can just go to the article. It's a nice article published in JAMA last year. Right. So the third factor is a cardioembolism. The COVID-19, this is not a very important risk factor, but still COVID-19 causes myocarditis and the cardiac dysfunction, which result in arrhythmia, so the heart failure or microinfarctions. So that can give rise to give rise to cardioembolic strokes. So what about the coagulopathy and anticoagulation? So the patient can develop intracellular hemorrhages or the subarachnoid hemorrhages associated with the COVID-19 infection. So one study looked at 3,824 patients with COVID-19, and they found the ICH risk is about 0.9%. So this includes primary hemorrhages and also the secondary transformation of the ischemic strokes, That's about 75% of the population, the cohort had ischemic strokes transforming into hemorrhagic strokes. What about the cryptogenic strokes? Now, the earlier studies showed up to 50 to 65% of the strokes, they couldn't find a cause. So it could be probably due to the incomplete evaluation at the initial stage of the pandemic, where we didn't have much of a clue how the disease, the infection is causing the strokes. But with the finding of more evidence, I think now we know it's due to the hypercoagulable state, which is associated with the infection. So the meta-analysis, including 70,000 patients, found there are atypical and the novel mechanisms, and the mechanisms are the ones that I discussed with you in the previous slides. Right, so what about the COVID-19 vaccination and the strokes? So it's something that people are worried about, whether should I get the vaccination or should I not? So I have diabetes, I have hypertension, maybe I had a stroke in the past, so should I get this one or not? So the thrombotic state is mainly associated with two vaccines. Those are the two vaccines that I mentioned here, not put the names of the two vaccines. So these are two DNA vaccines. The problem with these vaccines were the adenovirus, the vector that could bind to the platelet factor 4, and that can trigger the production of antibodies, which could result in formation of clots, even though the patient has reduced number of platelets. So they have low platelet with the thrombosis. And it's called autoimmune, the condition is called autoimmune vaccine-induced thrombotic thrombocytopenia. And usually that is seen 5 to 30 days post-vaccination. So in the first month of vaccination, if the patient develops a stroke, we can think of this condition. And one of the prerequisites is that the patient should have a lower platelet count, because it's not just a vaccine. Even the patient with hypertension or diabetes, they can still develop a stroke as the normal people, right? So the important thing is having a low platelet count, and the post-vaccination, that is an important point there. So should we get vaccinated or not? Right, so there's a study done in UK. They looked into the vaccination and what will happen if you don't get vaccination. So is there an increased risk with this vaccine or not? So they looked into the two vaccines up here, that is the AstraZeneca and the Pfizer, two vaccines, and also the patients who had infection, who didn't have vaccination, but who had the infection. The patients who had the vaccination are in the dark purple and the orange. And the one with the pink, or the dark pink, or is the patient who had the COVID-19 infection. So if you look at these numbers, if you look at the plot, you can see the patient who had the infection, they had a higher chance of getting the thrombosis. So here is the venous thromboembolism, the second row, and the fourth one is the venous sinus thrombosis, that what most of the patients or the doctors were worried about, and the ischemic strokes, myocardial infarctions. So they were higher in the patients who actually had the infection. And patients who are vaccinated, even with the vaccines, they're thought to give rise to increased risk of clots, they're still low. So what is the recommendation? So what the Stroke Association of UK says, the benefit of vaccine outweigh the risks, including the stroke survival. So even if your patient had strokes in the past, even if you have vascular risk factors, the vaccine, the benefit outweighs the risk. So this is something important we should understand, and it's important when you discuss the vaccination with the patients. So what about diagnostic evaluation? So as if like a normal patient, all the patients who comes with a stroke, they should have the same diagnostic evaluation. But if you suspect, they should be screened for COVID-19. So if the facility is available, they should be checked. Is it important? Yes. One thing is for the appropriate isolation measures to control the infection for the family members, the health staff as well. And also, if you know the patient is positive for COVID, then you can look for maybe development of systemic symptoms, maybe respiratory symptoms or any other complications. And also that's important for the prognostication as well. And there's one study in UK, it's called the CETICOS, that looked into the mortality and morbidity of patients who had a stroke with COVID-19. And what they found was when compared to the controls, the cases had higher mortality and morbidity. And this plot shows that one. If you look at the cases and the controls, the mortality and morbidity was higher, which was very significant, less than 0.0003. So the numbers were significant. The management, the same standards of care as for patients without COVID is carried out for patient COVID as well. And the important thing is that carrying out the necessary local guidelines on the infection control. But there are a lot of challenges in the COVID-19 era when you have a patient with a stroke. One thing is the scanning and the transfer of patients to hospital and the scanning facilities to get a proper time slot and the cleaning of the scan machines, beds. So there are a lot of strain on the radiology staff as well. And also there's increased strain on the emergency services in our country's 19. So there's increased risk on this, increased strain on these ambulance services and the strain on the emergency room and the staff. And also when the pandemic was high in our country, so we had to convert the stroke units, neurology units, even medical units to COVID-19 wards. So we tend to, put more focus on the COVID-19 than the stroke patients. And also these patients needs physiotherapy, speech therapy, occupation. So there's a lot of patient contacts, close patient contacts. So there are problems, the concerns when you're going to manage patient who's positive COVID with the stroke, when they need physiotherapy, speech therapy, or the occupational therapy. Right. So what about the thrombolytic or the reperfusion therapy? So IV thrombolytic therapy can be given as any other stroke patient. We don't have controlled studies on this, but the anecdotal data do not suggest that there's obvious safety concerns with IV antiplaques. And the mechanical thrombectomy, the same guideline apply for these patients. You can continue with the mechanical thrombectomy with the local infection control guidelines. But this patient increase reocclusion rates due to the hypercoagulated state. Well, this is for the patients who are not in a systemic unwell patients. But if a patient ICU or HDU develop a stroke, then the management has to be taken case by case, because these patients have systemic complications. Maybe they have heart failure, maybe they have respiratory failure. In that case, taking a patient for making a thrombectomy or giving IV thrombolysis is not very straightforward. So they need to have a quick MDT to decide on whether should be thrombolized or not. There's no just reason for us to give anticoagulation therapy for all the patients who are having stroke in COVID-19. It's only for the clear-cut indications such as atrial fibrillation or the severe heart failure, because these patients have increased risk of bleeding as well, especially when they have a low platelet count. And also the severity of the systemic illness has to be thought of. For example, if they have liver failure, the acute infection, systemic illness, you can't give, giving warfarin is going to be a problem when they have a liver failure. What about the management of vaccine-induced thrombosis? So that is managed with anticoagulation. The studies are mainly for direct oral anticoagulation, but here what we use is warfarin and the IVIG. The second stroke prevention would be same as for a patient who did not have COVID. So the management of risk factors such as hypertension, diabetes, dyslipidemia, atrial fibrillation, smoking. And the beginning of the pandemic, there's a lot of concern, should we give ACE inhibitors or angiotensin receptor blockers like captopril, enalapril, losartan, because the virus gain entry into cells to the AC receptor, S2 receptor. But later they found giving ACE inhibitors or the angiotensin 2 receptor blockers is not going to be a problem. So if your patient is on ACE inhibitors or angiotensin 2 receptor blockers, you can continue without much of a problem. So what about the prognosis? As I showed you previously, these patients tend to develop more severe strokes, especially these strokes tend to be large vessel strokes, and also they can develop multi-territory strokes. So invariably it's going to be a severe stroke, and therefore they have a higher mortality and the morbidity. So these are the figures from two large studies. One is a global COVID-19 stroke registry, and the other one is New York study in New York hospitals. So they found the patient with the COVID-19, they have a higher chance of, they had higher mortality and morbidity compared to patients who did not have COVID. Right, so in summary, acute ischemic stroke is an important complication of COVID-19 infection, and is due to the dysregulation of the coagulation system. And the large vessel occlusion and the multi-territory infarction seems to be an important etiology in these patients. And the hypercoagulable markers such as D-dimers and the fibrin levels are markedly elevated in these patients. And the community guidelines, the stroke care is a challenging problem during the COVID-19 pandemic. And these patients are managed as the standards of care should be same for the patients COVID and COVID-19 positive or COVID-19 negative patients, but still we have to follow the local guidelines for the infection control. Right, thank you very much. I think we're open for questions if you have any.
Yeah, Dr. Sajitha, thank you very much for that very comprehensive lecture, and it's a very relevant topic on this pandemic situation. We have a question. What is the definitive treatment for COVID-19 myocarditis induced thromboembolism? Do you have any concern about?
It's like this. If the patient, now there the patient needs to be evaluated with Holter and also the echocardiogram. If the patient is having cardiac thrombosis, then the patient needs anticoagulation. I think that is probably what what they're asking. Is that the question?
Yeah, that's the question. For the myocarditis in what is with the myocarditis and thrombosis?
Thrombosis, right? Yeah. I mean, for the myocarditis is going to be supportive. I mean, even for most of the complications of COVID-19, we don't have a specific treatment. Especially if you look at the encephalitis or the encephalopathies, we don't have a specific treatment. People have tried giving steroids, hydrosteroids for these patients, but there's no much evidence to suggest they are going to work. So even myocarditis, I don't think at the moment there's no place for steroids. You can correct me if I'm wrong. I'm a cardiologist, please correct me. But for the thromboembolic state, we have to look whether the patient having no ejection fraction, whether the patient having heart failure with the myocarditis. If it's any cardiac thrombosis, then the patient needs anticoagulation.
Thank you very much. So any other question from the audience? Okay, once again, thank you very much, Sajitha, for that wonderful lecture. And for the next lecture, may I invite Dr. Jagat Munasinghe, consultant pediatric neurologist at Sinuma Bandaranaike Specialized Hospital, Children's Hospital, Peradeniya. He's going to talk about clinical terms, definitions, and classifications in epilepsy diagnosis. Over to you, Dr. Jagat Munasinghe.
Good morning. Can you all hear me? Can you hear me?
Yeah, yes, we can hear you.
Okay, right. So today's topic for me is terms, definitions, and classifications in epilepsy diagnosis. So these are the terms actually which are still used. So there are so many here. For example, simple partial seizure, complex partial seizure, conversion, fit, and seizure disorder, and so on. Actually, these terms actually sometimes have no meaning. For example, if you take simple partial seizure, that means that seizure is uncomplicated and incomplete. So these terms do not give any particular meaning. That is why we need to change the nomenclature, the classification, and the definitions. So my talk will be based on International League Against Classification of Epilepsies, published in 2017. So actually, why do we need standardized terms and classifications in epilepsy? The main objective is to arrive at a comprehensive epilepsy diagnosis, including the etiology and comorbidities, so that we can address those issues, especially in the management. And also we can give a better prognosis. And this is important to communicate with the professionals as well as with the family and the patients. And we had to have a solid framework in all those terms and classifications to have good quality epilepsy research. So if a child comes to you, or if an adult comes to you with a paroxysmal event, so before jumping into a diagnosis of an epileptic seizure, so there are two things that you have to do. So first thing is you have to rule out all the seizure mimics, which can very closely resemble seizures. For example, syncope with some atypical features. For example, they can have eye deviation, stiffening, and even some incontinence even, and movement disorders and pseudo seizures and so on. So even if it's a proper seizure, so this seizure can be a provoked one. For example, due to encephalitis, or maybe electrolyte imbalance, head injury, and so on. So the first step is to rule out all these seizure mimics and also provocative factors. Then we can decide that this is an epileptic seizure. So once we have that diagnosis, then we can go through the International League Against Epilepsy 5-axis diagnostic framework. So this is the main topic that I'm going to deal today. So before that, the definition of a seizure, so this was published in 2005, but still today valid, this is also valid today. A seizure means a transient occurrence of signs or symptoms due to abnormal or excessive synchronous neuronal activity in the brain. And this is the definition of epilepsy, which was published in 2014. So this is a particular disease entity where the individual has a tendency to have recurrent unprovoked seizures. So this is a disease in that individual. Just because someone has a seizure or several seizures, it doesn't mean that that person is having epilepsy, because these seizures could be due to certain provocative factors in some. So there are 3 scenarios where we can make a diagnosis of epilepsy. So number 1, the easiest is if a patient comes to you with 2 seizures, 24 hours apart, then you can easily make a diagnosis of epilepsy. So what if a child or an adult comes to you with a single seizure? Then again, if there are certain associations where those make that person susceptible to have more seizures within the next couple of years. So if we can get the history and confirm those risk factors, then we can make a diagnosis of epilepsy. So statistically, actually, there should be a probability of 60% having another seizure within 10 years. So those associations, for example, a child with developmental delay, a child with structural brain abnormality, maybe a child with some neurodegenerative disorder or neurocataneous syndrome. So those situations, actually, we can make a diagnosis of epilepsy even with 1 seizure. And even with 1 seizure, if we can make an epilepsy syndrome diagnosis. So this I'm going to discuss in within few minutes. Then again, we can make a diagnosis of epilepsy. And so this is the diagnostic framework for the 5-axis diagnostic approach published by the International League Against Epilepsy. So this has actually 5 areas. So about the seizures and epilepsies, there are 3 tiers. So number 1 is classification of the seizure type. So that is divided into focal, generalized, and unknown. So if the seizure arises from one hemisphere or one part of the hemisphere, then that is called a focal seizure. When the seizure starts from both sides at the same time, then that is a generalized seizure. But if we haven't have that categorization, then we can leave it as unknown seizure. For example, if the first part of the seizure in the history is missing, then probably we'll have to settle with unknown seizures. So the next step is, once we diagnose an epilepsy, then we can divide that into focal, generalized, combined generalized and focal. And if we can't make that diagnosis, then we have to settle with this unknown category. So out of all these epilepsy types, there are certain epilepsies where you identify a certain pattern in terms of seizure onset age, seizure types, EEG manifestations, and changes in the imaging and so on. So we might be able to make a diagnosis of an epilepsy syndrome. So once that is done, we have to find a etiology for the epilepsy type. For example, it can be structural, genetic, infectious, metabolic, or immune. And we have to find out whether there are comorbidities associated with that. So this is the diagnostic framework for epilepsy. And epilepsy is not a single diagnosis. There are so many associations that we need to identify for the management purpose. So let's take the first axis. So that is the classification of the seizures. So this is an expanded version of the 2017 International League Against Epilepsy seizure type classification. So in that, first we'll take focal onset seizures. That is first divided into focal aware seizures and focal impaired awareness seizures based on the loss of awareness. So if the awareness is preserved throughout the seizure, then that is called focal onset aware seizure. If at any point, if the awareness is lost, then that is an impaired awareness seizure. So the next categorization is depending on the motor onset or non-motor onset. So there are two main categories. Again, we have to pick the first most prominent feature and then decide whether it's a motor seizure or non-motor seizure. So the motor seizures would be automatisms, atonic seizures, clonic seizures, epileptic spasms, hyperkinetic seizures, myoclonic seizures, and tonic seizures. The non-motor onset seizures would be autonomic seizures, behavior arrest, cognitive seizures, emotional seizures, and sensory seizures. And if the seizure starts from one side, and if it spreads to the other side, the newer term for that is focal to bilateral tonic-clonic seizure. So let's take the generalized onset seizures. That has mainly two categories, motor seizures and non-motor seizures again. So generalized non-motor seizures are actually absences. So that has four types: typical, atypical, myoclonic, and eyelid myoclonia. In the generalized category, actually, there's immediate loss of awareness. And the motor seizures under this category would be tonic-clonic, clonic seizures, tonic seizures, myoclonic seizures, atonic seizures, epileptic spasms, and there can be combinations such as myoclonic, then followed by tonic-clonic, myoclonic, then followed by atonic seizures. So if we don't know the onset, then we have to settle with this unknown onset category. Again, the seizures will be motor and non-motor. Motor seizures will be tonic-clonic or epileptic spasms, and the non-motor ones will be a behavioral arrest. And if we do not have the proper history throughout the seizure, and if we are convinced that this is a seizure, then we can classify that under unclassified category till we have further information. So let's go through all the seizure types, the descriptions. A myoclonic seizure would be a sudden onset, non-rhythmic. These are actually single jerks lasting only for milliseconds. And in that spectrum, epileptic spasm, in that, so there's sudden flexion on the wrist of the waist, and also flexion and extension of the arms. And those come in clusters, especially when the child is very drowsy during a waking period or getting into sleep. And the seizure duration is only 1 to 2 seconds. And the tonic seizures would be increased tone with or stiffness, and the duration is more than 2 seconds. And the clonic seizures would be actually rhythmic, regularly spaced, stereotypical movements. In an atonic seizure, there will be a sudden loss of tone lasting 1 to 2 seconds. So all these can be either generalized or focal. automatisms and hyperkinetic seizures, actually, these are focal motor seizures. In automatism, what happens is there's coordinated, repetitive, and purposeless motor activity. For example, swallowing or lip smacking or hand automatisms and so on. Hyperkinetic seizures would be thrashing and pedaling movements. And examples of these combined motor phenomena, the seizures can be tonic-clonic or myoclonic followed by tonic-clonic, which you see in juvenile myoclonic epilepsy. And the seizure can be myoclonic followed by atonic. And this kind of seizure you see in Douce syndrome or Lennox-Gastaut syndrome. So let's go through a few non-motor seizures. The meaning of a behavioral arrest is sudden cessation of motor activity or speech with a blank stare. And the autonomic seizures can take the form of changes in heart rate, blood pressure, skin color. There can be goosebumps or sweating, abnormal GI sensations, and vomiting. And the cognitive seizures examples will be hallucinations, change in language function, and abnormal thinking and feeling. This common déjà vu and jamais vu phenomena, actually, so those are terms used to describe the changes in the familiarity of the self and the surrounding. So the emotional seizures would be fear, anxiety, and pleasure. And there can be sensory seizures in terms of changes in the vision, hearing, smell, taste, and there can be numbness and tingling on one side. So let's talk about generalized non-motor seizures. So only the absence seizures come under this category, but there are 4 types. A typical absences, the definition would be sudden interruption of ongoing activity with a blank stare with some upward eye deviation. And these seizures last only few seconds, maximum 30 seconds with a rapid recovery. And these children can get up to 50 to 100 seizures a day, very frequent. So in atypical seizure, it's the same thing, but there can be very slow onset and offset. And because of the tone abnormality, so there can be manifestations. Suddenly, they can just drop down because of the atonia. And myoclonic absences, again, the myoclonic jerk, and it can be followed by an absence seizure. And there's this special absence seizure that is eyelid myoclonia with absences. So in that case, actually, there's forced deviation in the eyes with some eye blinking or eye twitching. And this is triggered by eye closure or photic stimulation. This particular type of seizure you get in a syndrome called G1 syndrome. So let's have a look at a few videos. So this is a child who is around 5 years, who is writing. And there's sudden cessation of the activity. And there's a blank stare and few oral automatisms and eye blinks. And it lasted only a few seconds and he resumed whatever he was doing. So this is a typical absence. So let's move on to the next seizure type. So this is an infant who is asleep. And there's sudden flexion of the trunk associated with sudden flexion of the upper limbs and lower limbs. It is more pronounced in the upper limbs, and there was associated crying. And these seizures come in clusters, one after the other. So each cluster can last up to a few minutes, and there can be many clusters a day. Again, so this is an adult. So actually in the video, the initial part of the seizure is missing. But what we can see is there's twitching of the oral musculature and twitching of the eyelids. And you can see that there's some clonic movements on the right lower limb and also the upper limb. So the seizure is gradually evolving to involve the both sides. So these are very vigorous myoclonic jerks. and this is followed by a tonic phase. So we can call it a focal to bilateral clonic tonic seizure. So initially there was a clonic phase and followed by some tonicity. And this is another seizure where you can see thrashing upper limb movements and some pelvic thrusting. So this is a nocturnal seizure. So this is called a hyperkinetic seizure, which usually comes in frontal lobe epilepsy. So let's go through one scenario. A mother finds a child having a seizure in bed, and what mother sees is bilateral stiffening followed by bilateral shaking. The onset wasn't seen, and so we can categorize this as onset unknown tonic-clonic seizure. But once we have done the EEG and the MRI, so that has shown focal changes. So then we can qualify the diagnosis as focal to bilateral. We can modify the diagnosis as focal to bilateral tonic-clonic seizure. So we might identify certain patterns in focal epilepsies. Actually, the classification is based on the onset of the seizure. So we go by the symptoms at the onset of the seizure, not by propagation, but seizure can propagate. So this propagation can cause various other combinations of signs and symptoms, which is called the semiology. And this is important to localize and lateralize the focus of the seizure to find out which hemisphere is involved, whether it's right or left, or which lobe is involved. So typically, a focal seizure will consist of an aura, ictus, or the proper seizure, post-ictal periods. Very rarely, it can be preceded by a prodrome, maybe a few hours before, or maybe a few days before. They can have irritability, headache, and change in mood, and so on. So let's take this example. There's a 12-year-old child who is right-handed, presenting with a rising epigastric pain, or rising epigastric sensation, which is of temporal onset. And also that child shows some oral automatisms, maybe swallowing or some lip smacking. And left-hand automatism, which points to the ipsilateral side, again, the left side of the brain, and late head turn to right side. So that is contralateral onset, again, left hemisphere. And ultimately, child becomes aphasic, involving the dominant hemisphere, which is left. So with all this information, we can come to the conclusion that the seizure started from the left temporal side, or the left temporal lobe. And we can confirm that with an EEG and also by doing an MRI. So when there are changes or abnormalities in those relevant areas, we can call it clinical electrical radiological concordance. Actually, going into these details is important because this may be a candidate for epilepsy surgery. So let's go to the classification, the axis 2. So that is again classification of the epilepsies. So initially we classified the seizure types. Here we classify the epilepsy types. So that is again divided into generalized, focal, combined generalized and focal, and unknown epilepsy, depending on the seizure types and also changes in the EEG and the MRI. So epilepsy syndromic diagnosis is the third axis of the third tier. So what is a syndrome? It's a cluster of features incorporating various parameters such as seizure type, EEG findings, imaging findings, which come together to make a syndromic diagnosis. So these are the factors which can determine epilepsy syndromes: age of onset and age of remission of the seizures, seizure type, EEG findings, imaging findings, and the functional level, triggers, and also diurnal variation of the symptoms. There can be family history suggesting of some epilepsy syndrome, and also genetic studies. So there are many epilepsy syndromes here actually. So the syndromes are arranged here depending on the age of onset. Neonatal onset ones, infantile onset ones, childhood onset, adolescent or adult onset, or epilepsy syndromes coming in any age. So I'm not going to go through all these individual syndromes, but I have pulled a few epilepsy syndromes which are common. So under these idiopathic or genetic epilepsy syndromes, the common ones are childhood absence epilepsy, where they come with absence seizures. The age of onset is 4 to 10 years, and it's a self-limiting illness. And the EEG shows normal background and generalized spike wave discharges at 3 Hz frequency. If we take juvenile absence epilepsy, they come with absences and rarely with generalized tonic-clonic seizures or myoclonic seizures. And the onset is late adolescence or maybe early adulthood. And these can be lifelong epilepsies, really. They are not self-limiting. And the EEG shows normal background. And in addition to generalized polyspikes, generalized spike wave discharges, there can be polyspikes. So if you take juvenile myoclonic epilepsy, the predominant seizure type is myoclonic, but they can have generalized tonic-clonic seizures and absences also. The age of onset is around 10 years, or maybe later than that. And again, this is going to be a lifelong illness in many. And the EEG shows a normal background and 3 Hz generalized spike wave discharges and high amplitude polyspikes. And also in about 40%, there can be photoparoxysmal responses, that is abnormal changes during photic stimulation. So one other syndrome is generalized epilepsy with generalized tonic-clonic seizures alone. So they get only GTC seizures, and the onset is again childhood to mid-adulthood. Again, the diseases tend to be lifelong, and in the EEG, there can be normal background and generalized spike wave discharges. And let's talk about two important focal epilepsy syndromes. Childhood epilepsy with centrotemporal spikes. So previously this was called benign Rolandic epilepsy, and then later on benign epilepsy with centrotemporal spikes. The current terminology is childhood epilepsy with centrotemporal spikes. Actually, in 2021, there's a new classification just at draft level. It's only a proposal, and in that case, they have suggested the name self-limited epilepsy with centrotemporal spikes. So the names are changing very rapidly. And in this particular type of epilepsy, they come with nocturnal seizures involving the hemifacial region. Usually these are focal motor seizures. Sometimes awareness can be preserved, and there can be some sensory symptoms as well. So age of onset is usually 3 to 14 years, and this is a self-limited epilepsy. The EEG shows, we have to do a sleep EEG to diagnose this condition. The EEG shows normal background and sleep activated bilateral centrotemporal spikes with some other special features. This paniotopolar syndrome, actually this is earlier called benign occipital lobe epilepsy, early onset. And the current name is paniotopolar syndrome, and in the future it will be called self-limited autonomic epilepsy, where the seizure types will be autonomic. They can be sudden atonia and also loss of consciousness and vomiting and becoming suddenly limp, and there can be tachycardia, bradycardia, and so on. And the age of onset can be as early as 1 year, and it can go up to 13 years. And this is a self-limited form of epilepsy. The EEG will show normal background and occipital discharges of high amplitude. So out of those epilepsy syndromes, so there's a category called epileptic encephalopathies. So let's see what that is. So these are actually a heterogeneous group of epilepsies where the epileptic activity, the seizures and the interictal discharges can impair the cognitive and behavioral function, which is beyond what is expected from the underlying pathology. For example, a child with cerebral palsy can have some epileptic encephalopathy such as Lennox-Gastaut syndrome, and that can lead to developmental arrest or developmental regression, which is not expected in cerebral palsy without any epilepsy. So let's discuss only a few epileptic encephalopathies. So neonatal onset epilepsy, epileptic encephalopathy, this early infantile epileptic encephalopathy, and they come with tonic spasms. And when you do an EEG, there can be suppression burst pattern, and also the etiology usually structural or genetic. And if we take infantile spasms, the correct term is actually West syndrome. So they come with epileptic spasms during infancy, and the ED shows hypsarrhythmia, and usually the etiology is structural or genetic. And this Lennox-Gastaut syndrome, again, they come with multiple seizure types: atypical absences, tonic seizures, atonic seizures, myoclonic seizures, spasms, so it can be anything. And their development is abnormal, either there's delay or regression, and there are typical EEG changes, and also the etiology can be structural or genetic or rarely metabolic. So what is the role of doing an EEG to diagnose epilepsy? So the EEG can only support the diagnosis of epilepsy because it cannot exclude epilepsy. The reason is that interictal EEGs, in 30% of the time in children with epilepsy, it can be normal. So we have to have a clinical diagnosis. And also a normal population, in about 10%, there can be EEG abnormalities. So if we take children with developmental delay, structural abnormalities, this percentage can be as high as 80%. So they will not have epilepsy, but still only the EEG abnormalities. So this is a difficulty in interpreting an EEG in the diagnosis of epilepsy. Just to give an example, so this is a awake EEG of a 13-year-old child presented with myoclonic seizures and a single generalized tonic-clonic seizure. So as you can see, this is a awake background, and there are spike wave discharges involving both hemispheres. So this is juvenile myoclonic epilepsy. And this is a 8-month-old baby present with developmental delay and arrest, and coming with epileptic spasms, and the EEG shows very abnormal background and very chaotic pattern of various types of discharges, making into hypsarrhythmia, and this is West syndrome. This triad is called West syndrome. So this is to show that you need the clinical details as well as the EEG to make a diagnosis of a particular syndrome. So let's talk about the etiological diagnosis, that is the axis number 4. So the etiologies can be structural, genetic, metabolic, or infectious or immune. And if the etiology is unknown, then you can call it unknown etiology. To get information with regard to this, actually, we need to investigate the child with neuroimaging, in relevant cases, genetic studies and CSF studies, and also extended metabolic screening. Because sometimes refractory epilepsy can be a feature of autoimmune encephalitis and certain metabolic conditions, even chronic infections. So we need to investigate and find out. So let's go through the last axis, identification of the comorbidities. So there are so many comorbidities. Actually, these comorbidities can be more severe than the epilepsy itself. For example, a child who is having very occasional seizure once a year, but having severe behavioral issue, I think the major problem is the behavioral issue. So that is why we need to identify and address those. So what is drug-resistant epilepsy? So let's go through the definition. Failure of adequate trials of 2 tolerated, appropriately selected anti-epileptic drug schedules. So it can be monotherapy or in combination. If you have tried 2 medications and if you haven't achieved seizure control, then you can call it drug-resistant epilepsy, but they haven't given any time period. And before diagnosing this, actually, you had to rule out all the false refractoriness, the causes, wrong diagnosis, wrong treatment, poor drug compliance, and ongoing triggers of the seizures. And when do you call the epilepsy has resolved? So there are 2 occasions where you can do that. So if the epilepsy type is a age-dependent epilepsy, for example, childhood epilepsy with centrotemporal spikes, and if the child is older than that particular age limit, then you can declare that the epilepsy has resolved. In other patients, if the patient is seizure-free for more than 10 years and off treatment for more than 5 years, again, then you can declare that the epilepsy has resolved. So this is actually the take-home message. When you come across a child with epilepsy or suspected seizure, just first try to identify the seizure, whether it's focal, generalized, or unknown. Once you diagnose epilepsy, then try to identify whether this is focal, generalized, combined generalized and focal, or unknown. So once that is done, try and identify an epilepsy syndrome. Because identifying an epilepsy syndrome is important because that has prognostication value as well as treatment implications and so many other things, important things in patient management. So once that is done, try to identify the etiological factors, whether it is structural, genetic, infectious, metabolic, and immune. For that, actually, you have to do certain investigations and try to identify all the possible comorbidities. Actually, this is the most important part, so that you can help the patient by dealing with those comorbidities. So before winding up, actually, so these are older terms and new or more appropriate terms. So instead of calling conversion of fit, call it a seizure. So seizure disorder, actually this term is still in use, but which is a wrong term. Use the term epilepsy, and you can use focal aware seizures instead of simple partial seizure, and focal impaired awareness seizure instead of complex partial seizure. And better to avoid benign prefix. The reason is that the epilepsies are not really benign. Actually, they will at least have some impact on the social aspect of the patient, even if the seizures are under control. So use self-limited, and rather than saying secondary generalization, try to call it focal to bilateral tonic-clonic. So that ends my presentation, and thank you very much for listening. So if there are any questions, then I'm happy to answer.
when the patient is still. The next common we see is a migraine. It's a episodic vertigo, like episodes of migraine, and it may associate with the migrainous headache, or it may not. It may associate just stimulus sensitiveness as of a migraine, like photophobia, phonophobia, which gives you a clue that it is a migrainous vertigo. Next, we come to vestibular neuritis, which is an acute presentation. It is a self-limiting inflammatory process, like could be a viral etiology. So it lasts days up to about a week, and gradually patient recovers. Then we come to Meniere's disease. Not so common, but we come across. It is caused by a fluid shift within the semicircular canals. There's endolymph accumulation, and this comes on over minutes, and it lasts about 5 to 6 hours, and maximally about 24 hours. And it associates with auditory symptoms, usually ear fullness, tinnitus, and with the episode, there can be hearing impairment. So there are recurrent episodes. With each episode, their hearing will decline. So this is an episodic vertigo with associated auditory symptoms, and it lasts up to about 24 hours. Then we come across TIAs and stroke, where the other neurological symptoms can directly point to you that there is a central element involved, like a stroke. There can be motor sensory symptoms, horns, and in coordination, which clearly indicates it's something more than a vestibular etiology. So there are other less common causes of vertigo. I will just briefly mention. The Ramsay syndrome is herpes oticus, where you will have additional features like facial weakness, hearing impairment, and there can be vertigo and vesicles in the ear canal. And there is this perilymphatic fistula, where there is communication with the middle ear and the semicircular canals. So there can be triggered attacks with sounds. And in this, there's a particular sign where you can have nystagmus with pressure on triggers. And other neurological causes also can cause vertigo, like multiple sclerosis. And there are a lot of other auditory causes like cholesteatoma, autosclerosis, which can cause vertigo, but of course with auditory symptoms. And there are other rare causes also, which I will not go into much detail. So with the history alone, you would notice that we can arrive at a diagnosis most of the time, at least about 70% of the time, we can identify what it is causing this vertigo. So going back, you will notice that we first have to notice that it is a real vertigo, and we need to establish the time course, whether it is minutes, hours, or whether it is a pattern of a migraine, and so on, and find out whether it is a triggered vertigo, like in BPPV, whether it comes on with turning in bed or with head movement. Associated auditory symptoms clearly indicated auditory cause, and clear-cut neurological symptoms indicate the central vestibular cause. And always find out if the examination is normal and there's no central auditory findings, whether there's a history of migraine, because it's so common. You will assess the patient's risk for a vascular event also. So you will notice that timing in differentiating causes of vertigo is important, because it differs with each each etiology. In BPPV, it is minutes, but you need to establish that it comes on and settles within a minute. Unless you ask, the patient will not tell that. And the TIA may vary, of course. Mania will last about 20 minutes up to a day. A migraine can be a few hours to a couple of days. And then labyrinthitis, an acute onset lasting days. A stroke also acute onset lasting days. Here comes the difficulty for us because differentiating a stroke from vestibular neuritis can be difficult if the stroke is causing isolated vestibular symptoms. So here comes the importance of a focused clinical examination to differentiate among these. Here comes the what I mentioned in my topic, the hints. It is a bundle of examination which helps us to differentiate among a stroke and a vestibular neuritis. So what does hints mean? HI means head impulse test, nystagmus, and test of skew. I will elaborate on these as I go along. So to understand the basics of clinical examination, we will see what is the normal physiology. The word, it is the vestibular apparatus that is key in causing vertigo. So the vestibular apparatus detects more head movement and it communicates with eye muscles and the spinal reflexes are there to keep the balance. So vestibular sensation, it is a sense of head position and movement, and it knows how and where the head moves and what speed it's moving. So this information is carried to the brain stem where reflexes, and one reflex of importance is vestibular ocular reflex, which brings on in bringing vertigo, because this reflex helps us to stabilize the visual objects that we see. Because the head is moving all the time, if the eyes moves along with it, we are definitely going to miss the objects that we are seeing. The images sit in the retina. But the vestibular ocular reflex prevents this. So if the head moves to the right side, this reflex makes the eyes move towards the opposite side so that it keeps targeting on the object of interest. So this is coordinated through several of gaze centers spanning across the midbrain and pons. And there's a lot of involvement of cerebellum, especially the cerebellum flocculus, in bringing about these smooth coordinated movements. There are these connections with cortical areas and thalamus, but of course it's the brain stem and the cerebellum that play a key role. So from now onwards, for the purpose of ease of explanation, we'll divide these areas to peripheral and central. So a vestibular apparatus involvement we will call a peripheral, and then stem nuclei and cerebellar and higher involvement will call as a central. So practically a peripheral one is a vestibular neuritis, and a stroke will cause a central. Central cause is a stroke. Same thing. So this is what I mentioned by vestibular ocular reflex. Wherever your head is moving, you can keep targeting on the object that you are interested in. You can test it yourself by checking. If you read this topic on top, whatever the way you move your head, you can very well read it without the image slipping on the retina. So this is done by the vestibular system. The misses on this pathways leads to vertigo. So there's a fascinating system of mechanoreceptors within this ampulla of the semicircular canals that brings on impulses and these reflexes, but I will not go into detail. For explanation, we will get the gist of it. What happens, this is to describe what happens in peripheral vestibular loss. So at baseline, there's a constant firing equal from both right and left side. So when the head is moving to one side, there's more firing from the turning side and inhibition on the opposite side. It is this difference that is picked up by the vestibular nuclei in the fontamental junction. It doesn't know anything about whatever is happening, but it picks up that there is a difference, and depending on where the difference is, they know where it is moving. So what happens if there's a vestibular dysfunction on one side? There will be lesser baseline impulse amplitudes, and other side remains normal. So what that is ultimately bringing on an imbalance, and there's more towards the normal side, as if the head is moving towards the normal side, but actually the head is not moving. So other cues like visual cues indicate that the head is not moving, but the vestibular system is indicating head is moving. So there's a discrepancy. So that's what brings the vertigo. And also in this situation, the vestibular nuclei thinks that head is moving to the normal side, and the eyes tend to drift as because of the vestibular ocular reflex. Eyes tend to move to the affected side, but the central system picks this up, make a corrective movement. So there's a slow drift of eyes to the affected side, followed by a corrective movement, which we call a corrective saccade to the opposite side. When this happens again and again, so there's a slow drift, a corrective movement, a slow drift, a corrective movement. Then we see what we call a nystagmus. So these nystagmus has peculiar features to a peripheral vestibular loss, because it will always slowly drift to the affected side, and correction is towards the opposite side. And it moves faster away from the affected ear. And there's another element which I will come to later, the head impulse test. So this nystagmus is a unique directional nystagmus. So it beats away from the affected side and higher amplitude towards the faster side. So in this sort of nystagmus, we see a slow phase and a quick phase. And we generally describe the direction according to the quick phase. Slow phase is pathological. So I'll come to the next point I mentioned earlier, head impulse test. This also assesses the vestibular ocular reflex. So we will later see what happens in a peripheral vestibular loss. So here what we do is we ask the patient to keep looking at the nose. So he is fixing on an object, and we try to move the head briskly to either side, 30 degrees, and bring it back to the center. So in a normal person, he should be able to keep fixing on the object of interest despite whatever these head movements are. So if you see in this person is a normal person. The head moves, eyes keep still focusing on the target. So it is a normal head impulse test. So what happens in a peripheral vestibular loss? As I said, if there's a dysfunction, eyes tend to slowly drift away, and there are going to be a corrective movement. So we can see this in head impulse test in a peripheral vestibular loss as a jerking, rapid corrective movement when turning to the affected side. So in this case, turning to the right, there's a jumping movement here, not there. You didn't see it much clearly here. You see it here. Okay. We are doing it slowly now. there is this jumping movement. So we call it a corrective saccade opposite to the affected side. So the eye is restricted to the affected side and there's a correcting movement to the opposite normal side. So now we looked at two elements of head impulse test, hints examination, a head impulse test and nystagmus. So head impulse test is abnormal in peripheral vertigo. It can be normal in central vertigo. So we looked at the nystagmus also. We looked at the nystagmus also. In peripheral vertigo, it is unidirectional. So what are the characteristics of central nystagmus? As I mentioned earlier, the central elements in the brainstem, there's a lot of brainstem nuclei and gaze centers that coordinate eye movements. For example, if you are looking to right side, it should be the right lateral rectus moving to the right side, and it should be the medial rectus moving to the right side. So there's this pontine horizontal gaze involvement with lateral rectus nucleus, and you have to coordinate with the third nerve nucleus, medial rectus component. So there's a lot of coordination and bundles involved here. And also, there's a lot of cerebellar input here. So we in the case of central vertigo, we are likely to find features unique to each of these centers of cerebellar involvement, like the you have right side. And now when looking to the opposite side, again it is, but then it is to the opposite side. This is called the direction changing nystagmus. It is a characteristic feature. If it's in all direction, it's a characteristic feature of cerebellum. If it is horizontal, it's a characteristic feature of brainstem involved. So what happens in this case of direction changing nystagmus to the head impulse test? We look at this patient. We are doing the head impulse test. So you don't see any jerking or correcting movements. She keeps solidly targeting on the visual target. So it is a normal head impulse test. So this is the characteristic of a central vertigo. So in a central vertigo, nystagmus is direction changing and the head impulse test is normal. This is what we are looking for in the hints examination. So the nystagmus, if it is direction changing, it is indicating a central nystagmus. If it is unidirectional, it's indicating a peripheral vertigo. So now we looked at head impulse test as well as nystagmus. So we'll move on to see what is this test of here. So we do what we call an alternative cover test. What we look here is whether there's a misalignment in the vertical plane. Now you see this eye is moving an upward movement, correcting a misalignment. That is abnormal. If you do it again, there is this movement. So it is an abnormal vertical skew. And there can be head tilt in this patient. So this is the bundle of examination, which we call hints examination, differentiating a central and a peripheral vertigo. So this came up somewhere in 2009 in the Journal of HA to diagnose a stroke, and they demonstrated that it is more sensitive than MRI in detecting an acute stroke in the first 24 to 48 hours after symptom onset. This is because if it is an ICH, we can of course see it in the CT scan, but if it is a ischemic stroke, if it is very early, CT is going to be normal. So differentiating it from a vestibular neuritis is based on bedside clinical examination. So in this regard, HINS is proven to be very sensitive, and this has been reinforced again and again and since the 2009 publication. So with that, I have explained what I meant by HINS examination. Now I will also mention something brief about benign paroxysmal positional vertigo, because it has its unique examination finding that allow us to localize where the problem is, in which canal the problem is. So the BPPV can be spontaneous, which we see in older age mostly, but sometimes in a younger patient, we see it in traumatic after trauma, where this calcium carbonate crystals can dislodge. And we have, just here, we have different symptoms and clinical findings and features of nystagmus unique to each canal. And there are procedures to elicit typical nystagmus unique to each canal by getting the patient to move to the canal tail of interest. So the posterior canal BPPV is the most common, for which we do what we call a Dix-Falk-type test. Here what we do is sit the patient on the middle of the bed and ask the patient to turn his head about 45 degrees and bring the patient down with the head end hanging down over the edge of the bed or over the pillow to a 45-degree angle. Like this. You move the head and bring the patient down. This will cause a typical nystagmus, which is torsional, upbeat, and it is torsional and upbeat. It beats upwards with some torsional element, and the affected ear is the ear facing the floor. So the features of these nystagmus are that there's little latency in onset of nystagmus. If you notice it in that old lady in the previous video, and there's increasing crescendo and decrescendo pattern of it. If you do the test again and again, you will see that the nystagmus fatigue. There's little latency, and it starts beating and faster, and then it comes down slowly. And it beats up towards the upper lid in case of posterior canal. So knowing these features are important because there can be very rare instance where there can be positional vertigo in a central cause, but that will not have this typical finding. So knowing the common thing will help you to be alert to other rarer and sinister causes. So I am going to conclude with that, but before that, I just mentioned, which I will go back to this thing that I mentioned early in my presentation. Vertigo occurs in acute and unilateral loss of vestibular function. It is because the imbalance is the one that causes vertigo. Imbalance of the vestibular input that causes vertigo. If there is bilateral vestibular failure, there is no imbalance. Both sides are affected, so there is not going to be vertigo. Also, if the vestibular loss is slow, there will not be vertigo because there are other compensatory mechanisms that take over these functions like central compensation and other sensory substitutions. So in these cases, we have different complexes of symptoms like oscillopsia and tilt reactions and drop attacks and so on. This is what we call oscillopsia. This is a patient with bilateral vestibular dysfunction. This clearly demonstrates the function of the vestibule because this patient cannot stabilize the image while he is walking along the road. The road oscillates because he cannot fix the image of the road on his retina because the BOR is not functioning. So with that, I will conclude on this is a very brief and simplified way to how to approach a case of vertigo. And thank you. Thank you all for joining and listening.
Thank you very much, Dr. Srini, for that wonderful lecture with some practical aspect as well. So now we have come to the last lecture. It's Dr. Danushka by Dr. Danushka Ratnayaka, consultant neurologist, teaching hospital Kegol. Thank you very much, Danushka, coming all the way from Kegol to deliver this lecture. He's going to talk on an approach to spinal cord syndromes.
Okay, so now I'm doing having sort of basically if I'm correct, I think I did the same lecture about 1 year ago, and but still the ASN and the people want me to repeat the same lecture. So it is an approach to spinal cord syndromes or the myelopathies. Now, so what is myelopathy? I mean, simply it is the disease of the spinal cord. So it could be due to different and the examination, it should be very directed examination. I mean, at the beginning you could do very from top to bottom examination, but as you go along and when you have a lot of experience, you can have a directed examination where you can start with a specific examination. And those two, I mean, one should be able to come to a sort of a possible diagnosis or a differential diagnosis at the end of these two, comprehensive history and an examination. And by doing further evaluation, I mean, it could be imaging, it could be various blood investigations, and lastly, the CSF will confirm your diagnosis, and as well as you can classify the etiology. Now, if you take the causes for myelopathy or the spinal cord syndromes, you can broadly divide into two categories, which are compressive causes and non-compressive causes. Now, if you want to further divide these two broad categories, you can have these subcategories. I mean, it could be traumatic. So it could be traumatic compressive. Mostly they are compressive. And now if you take a vascular cause, it could be compressive as well as non-compressive. Say, for instance, now if you take a hematoma, it could, I mean, it will cause compression into the cord. But if cord infarction, it is a non-compressive. So likewise, you can divide these and infections. Now, if you take a infection within the cord, so it is non-compressive. But in other terms, now if you have a epidural abscess, it is a compressive. And you can have inflammatory causes, autoimmune and metabolic. Commonly, what we are seeing is degenerative spondylosis and tumors. Now, these are the various causes. Now, as I have said, under compressive, you can have degenerative compressive causes, which is due to the spondylosis. That is osteoarthritis of the spine causing compression into the cord. And traumatic causes, infectious causes, as I said, I mean, it could be an abscess. And tumors, you can subdivide it into various categories depending on the location. Extradural, which is outside the dura, and within the dura. Within the dura, it could be extramedullary, which is outside the cords, but it is within the dural space. Or it could be within the cord itself. And then the vascular malformations, syringomyelia. Non-compressive causes. I think, I mean, these sort of causes, we better know by heart, because if you want to take a history, you need to know these things. Now, for instance, now if you want to ask about infectious cause, so I mean, if your patient is having abscess, epidural abscess, so and if you are suspecting an epidural abscess, you have to direct certain questions to that diagnosis. Now, I mean, from this point onward, basically the whole presentation depends on this single picture. Actually, what you need to know is the one on the left side, which is the cross section of the spinal cord. So what we have, I mean, these are basically, we have learned a lot of these informations from the day that we have started our career as medical students. So we have descending tracks, which are basically motor tracks, and ascending tracks, which are sensory tracks. Now, if you take descending tracks, mainly we are concerned about the lateral corticospinal tract, taking impulses from the brain or the cerebellum to the target organs, the muscles. And then if you take the ascending tracks, you have basically three things that you have to keep in mind to work out the various syndromes. Dorsal column, which conveys messages from periphery to the brain. They include fine touch, proprioception, and the vibration. And what is called the lateral spinal thalamic tract, which carries fibers taking messages of about pain and temperature. And the ventral spinal thalamic tract, which takes light touch. So now if you know this, actually, now you don't want to sort of memorize any of the things that are mentioned in upcoming slides, you can work it out. Now, if you take the clinical course of myelopathies, I mean, it depends on, I mean, it has very variable course. It depends on where the lesion and I mean, the degree of the lesion or the severity of the lesion. So you can have a myelopathy as a single event. So for instance, you can have transverse myelitis and then you could have complete recovery or partial recovery or no recovery at all. And there are certain myelopathies which are coming as recurrent diseases. For instance, demyelination. And it can come as multiphasic or the recurrent disease. And you can divide further all these causes depending on the time of time course, actually. I mean, if you get a sudden sort of something within days, you called acute myelopathy. Commonly, they are vascular in origin. Could be an infarction or a hemorrhage. And the subacute causes, which are basically between 2 to 6 weeks of duration. And if they are more than 6 weeks, they are chronic. So when you are describing something, you have to use these various terminologies. Regarding localization, now where do you suspect the myelopathy? I mean, basically, if you take if somebody is having now, if you take a history, and I mean, if in the history that you don't have anything to any abnormalities localizing to the face or the head, then you know that it is below the medulla. And generally, they are having bilateral signs. I mean, it could be motor signs, it could be sensory signs, or in combination. Motor deficits could be now. I mean, if you can remember the picture, that the cross section, you can have long track signs if you get any involvement of the corticospinal tracts, such as spasticity and brisk reflexes and positive Babinski sign, which are promoter signs. And generally in myelopathies, you get a sensory level. But again, I mean, it is very common to see in thoracic myelopathies where you have a level above which the sensations are normal, but below which all of them are abnormal. So if you are suspecting myelopathy, you have to look for this. And then you can have so-called segmental signs or the lower motor signs at the level of the injury, such as atrophy, flaccid weakness, and loss of reflexes. So below which you upper motor signs. Now, I mean, this is what that we want to know. So we have different myelopathic syndromes. About 7, I think. So the common ones are the segmental syndromes, dorsal posterior cord syndrome and anterior cord syndrome, Brown C cord, central cord syndromes, and certain pyomotor syndromes. And I have included the conus medullaris, which is the last part of the spinal cord. Now, going into the detail of each syndromes, what is called segmental syndrome. It is basically you lose all the functions of the cord at one segmental level. So you will see loss of all the functions, which could be total or incomplete loss. And that is because you get involvement of the all ascending as well as descending pathways. They are in the picture. Now this is a figure showing, I mean, this MRI shows a incomplete transection of the spinal cord, so that below which you get all the functions lost. I mean, it is most severe form, obviously. And all the sensations and motor functions will be lost below the level. And depending on the site of the lesion, you get various symptoms. So, I mean, if it affects from C1 to C8, you get all falling paralysis, which is called tetraplegia. And if it is between, now if you take the picture now from the T1 to L4 level, you get only the lower limb weakness, paraplegia. And in this case, you get loss of pain and temperature loss, as well as joint position loss. So this is what I have explained. So you get flaccid paralysis at the acute stage. And as the time goes, you get upper motor signs, which are, I mean, when you examine sort of an older injury, you could get increased tonus spasticity and hyperreflexias and clonus. Causes, although I have mentioned these two, still all other causes are applicable here. But commonly it could be traumatic and cord hemorrhages. Now moving on to the dorsal or the posterior cord syndromes. The term says it is posterior cord syndrome. So that you expect now, if you go back to the picture, the main tracks that can be affected are the posterior column. But still, depending on the extent of the lesion, you could have involvement of the corticospinal tracts, which are placed laterally in the cord. So you get great ataxias and paresthesias, and you can have corticospinal tract dysfunction, which are leading to again low motor signs in acute stage. And if it is chronic, as I mentioned before, you can have upper motor signs, and you will get which is a upper motor sign. And generally, people get incontinence. This is what now, this figure has limited only to the posterior column, so that you will get normal motor functions, because the figure does not show any involvement of the the green color, because there is no motor tract involvement. But in general, you can have involvement of the corticospinal tract as well. Isolated posterior column involvement will lead to loss of the vibration and proprioception loss. But if you examine the patient, their pain and temperature will be normal. Now, these are the common common etiologies which are coming with dorsal cord syndromes. Multiple sclerosis, specifically primary progressive form, tabes dorsalis, which is syphilis, and subacute combined degeneration of the cord, which is due to B12 deficiency and certain vascular malformations. And this is also very commonly we are seeing cervical spondylitic myelopathy. We see a lot of patients who are coming with ataxias, and if you dig into the history, and when you examine, you can clearly localize it into the syndrome into the cervical area, because they are telling that my swallowing and everything is normal, but I'm still feeling unsteady. So you have to think of cervical spondylitic myelopathy, which is very, very common. That is why I use a different color. So it is pressing the spondylitic changes leading into the compression of the posterior cord, posterior part of the cord. Moving on to the anterior cord syndromes, it usually includes the tracts in the anterior third of the cord. Now, if you take the picture into your mind, they are the corticospinal tracts and spinothalamic tracts, and certain descending autonomic tracts to the bladder. So if you get a corticospinal tract involvement, you get the, in acute stage, you get low motor signs, below which, and as the time goes, you get upper motor signs. And due to the involvement of the spinothalamic tract, you get a bilateral loss of pain and temperature sensation loss. You can understand why it is bilateral. And generally, or most of the time, these other sensations, like the sensations that are carried in the posterior column, vibration and pressure sensations, they are normal. Urinary incontinence is usually present because of the involvement of the descending orders. Now, if you take this figure, now you have motor loss. It is explainable because of the corticospinal tract. So that is why it
shows the yellow color, and there is no blue color because vibration and proprioception is intact, and pain and temperature will be lost because of the bilateral corticospinal tract. So at this point, I would like to again highlight the fact that why the full examination is necessary in analyzing a neurology case. So you can't just do pain and temperature and go away and say that, I mean, this is the diagnosis. So you have to do the full examination to sort of deeply analyze the case. So these signs and things I have already discussed, and causes are, I mean, it could be spinal cord infarction, especially anterior spinal artery thrombosis, which supplies most of the anterior part of the cord, about 2/3 of the cord, and disc herniation, which are compressive. So here also, you can still divide it now. If you get a patient with anterior cord syndrome, then you go back and think, I mean, whether this is a compressive pathology or a non-compressive. So, I mean, if it is a trauma or disc related, it is compressive, and it is not. I mean, if it is infarction, it is non-compressive. Likewise, each and every syndrome, you can work out the etiologies. This is an interesting syndrome again, hemichord. I mean, this was described somewhere around 1817, where you get involvement of the hemichord. So it is unilateral involvement of the tracts. Now, if you take this picture, so you get the lesion on the right side, so that you will get, because of the involvement of the corticospinal tract, you get more signs in the same of more functions, and ipsilateral loss of the dorsal column functions. Basically, they are vibration and position. So if somebody is complaining of, I have weakness on the right side of the leg, whole leg, and if you examine and if you detect right-sided absent JPS, then you, I mean, you know where you are. Then you have to check the temperature sense on the other leg, and then you know that it is Brown C code. Likewise, what you have to do is to work out the case. So that they get contralateral loss of pain and temperature because it crosses at the central canal level. Central cord syndrome, which is the involvement of the central part of the cord or around the central canal, but depending on the extent of the lesion, you get various signs. But if it limits only to this decussation of the pain and temperature, then you get only the sensory signs. But as the lesion extended, you get other signs. And this is very, I mean, the most important thing that you have to keep in mind is most of the time central cord syndromes, you get more upper limb involvement than the lower limb involvement. Generally, they are not having bladder bowel involvement, and recovery when compared with other syndromes, recovery also better with maybe minimal upper limb distal weakness. So you get what is called suspended sensory level just because of the, I mean, it is already explained why it is. You get the loss of pain and temperature sensation in the distribution of adjacent dermatomes because of the damage to the crossing spinothalamic fibers. Apart from motor signs, this is. So what you get in central cord are this combination of all these what is called suspended sensory level, and a motor signs which are predominant in upper limbs. Causes. So, I mean, it could be anything. I mean, if you go into that chart, but the common things are syringomyelia and intramedullary tumors, which are located close to the central canal. Pure motor syndromes, that is, they are basically having normal sensory examination and without any bladder involvement. This is also, we usually see these kind of patients. Commonly what we see is this primary lateral sclerosis, which is, I mean, entity of the neuron disease. I think hereditary spastic paraparesis patients also, it is not very common, but I mean, if you have motor signs only in the lower limbs, normal sensory examination and without involvement, and I mean, maybe you have a family history, but may not be. So you have to think of these syndromes, pure motor syndromes. And shock-induced myelopathies, polio, and this HTLV myelopathy. Corner cause, which is, you know what is the corners, I hope, and you get symmetrical signs rather than in coda, because the coda, which are the roots after the chord ends, these syndromes affect the last portion, end part of the chord, so that you get a combination of both upper and lower motor signs as well as symmetrical involvement. And when compared with the coda syndromes, the bladder bowel involvement is much more common. And you have additional signs as well, loss of penile reflexes and things, and loss of penile tone, and you can have impotence. And generally, you have a preserved ankle jerk, which is not seen in coda. Because S1 root is preserved. Now, this is what I have been talking about. I think, I mean, if you can remember this slide only, that is enough for your, I mean, future workup of cases. So now, if you take transverse chord lesion or segmental syndrome A, you have all the things absent below the level with the sensory level. I mean, if it is thoracic myelopathy, I mean, you have to specifically look for a sensory level. And hemichord or brown sea chord, you have unilateral motor function loss and pain and temperature loss, and your contralateral, unilateral motor and dorsal column proprioception loss, and contralateral pain and temperature loss. Central chord, I mean, depending on the extent, you will get the signs. I mean, if it is very narrow area, only around the central canal, you get something like this in the third figure. Or if it involves the whole other tracks, you get the other one, the involving all other tracks leading into motor signs as well as combination of sensory signs. And posterior chord syndrome, if you take only the posterior chord involvement, you get only the loss of proprioception and vibration, but rest of the things are normal. And in anterior chord syndrome, you get motor signs as well as pain and temperature loss. So now, if you remember these, and if you are interested, then you have to examine and find what the problem and where the problem and what are the tracks that have been affected. I mean, it is beyond the scope of this lecture to discuss the therapeutic approaches for myelopathies. I mean, but if you can just remember this graph, I think it would be enough. Now, if you myelopathy, or in simple terms, spinal cord syndrome. Ideally, you have to do MRI, which is very, very difficult to do in our setup, but still you have to do MRI. And if you find a compressive cause, you have to do the needful. It should be referred to the neurosurgical team. But if you find a non-compressive thing, you can have non-compressive myelopathy, or the patient is having signs of myelopathy, but when you do the MRI is normal. Then you have two options. Either you can repeat the study and see, especially if the signs are definite. And if you find any abnormalities, depending on the abnormalities, you have to elaborate on your investigations. For instance, now if you see any demyelinating lesions in the cord, so you go along that pathway to, identify the syndromes. You have various syndromes. Now, if you see an infection, then you have to do rest of the infection workup. For instance, if you get a case of a TB, you have to work up for TB. Inflammatory disorders, something like sarcoidosis, you have to work accordingly, apart from the basic MRI. And generally, this is very important. Now, if you do a LP on a patient who has signs of myelopathy, it could be normal MRI or it could be abnormal MRI. And if you do a LP and if you see inflammatory cells or inflammatory CSF findings, so you know that these causes are the possibility. It could be demyelination, it could be an infection or an inflammatory disorder. So that depending on your history and relevant other things and the available other investigations, you can go for a definitive diagnosis. Generally, in neoplastic or paraneoplastic processes and the vascular things, CSF will be normal. So now, maybe after diagnosing that you have a myelopathy, you would should proceed with a brain MRI. That depends on the case again, and certain cases you turn normal brain. Up to this point, now if you come to this point, so if you are not you haven't find a specific diagnosis after certain investigations, still they recommend to go for steroids, and then you can see a responsiveness. If no improvement, then you have to work the case again out. Sorry, you have to analyze it again, and maybe you have to repeat the studies, or maybe you have to repeat the study with contrast, or lumbar puncture with second line investigation, something like oligoclonal bands and things. So this is basically how do you investigate a case, and to basically the acute treatment. And if you find a specific diagnosis, obviously you have to treat that diagnosis. For instance, now if you confirm the case as multiple sclerosis, you have to treat multiple sclerosis. And if you confirm the case as subacute combined degeneration of the cord, you treat with B12. Likewise, you give the specific treatment apart from the symptomatic treatment. So basically the symptomatic treatment is you can treat for the numbness and maybe for the spasticity if it is a chronic case. And in acute cases, maybe the most important thing is to avoid deep vein thrombosis. I think that's the end of the talk. What you have to keep in your mind is, if you know this just basic neuroanatomical knowledge, if you have basic neuroanatomical knowledge, you don't want to memorize any of these things, you can work out the syndrome. And then the most important fact is to get a comprehensive history, because at the end of the history, most of the time you can localize the lesion, most of the time. But unfortunately, we have very limited time. What we are doing is basically clearing clinic list and all, but still we have to try to get a comprehensive history and very directed examination, and then the things will get cleared. And most of the, it is not, most of the syndromes are potentially reversible if you detect early. So that you have to be vigilant in taking history and examination and directing the relevant investigations. Thanks. Thank you.
Thank you very much, Dr. Dhanushka. Do you have any questions? Question? Dhanushka, there's one question. How do you differentiate superior branch MCA versus inferior branch MCA? How do you differentiate the superior branch and inferior branch MCA?
That depends on, so this is what they're asking is middle cerebral artery territory infarctions. In inferior branch, you get visual symptoms because of the involvement of the visual tracts. But not specifically in superior branch. What they're asking is superior and the inferior. Okay, so basically you have the signs of MCA infarct, and you can go with the visual examination, visual field examination. Yes.
Thank you. Any other questions? So that remarks the end of this wonderful session and the workshop on current updates on neurology in collaboration with Kandy Society of Medicine and the Association of Sri Lankan Neurologists. And officially, let me conclude. First of all, I must thankful to my sincere thanks goes to the President, the Association of Sri Lankan Neurologists, Dr. Gamini Patirana, and his council members. And a very big thanks to all the resource persons who shared their knowledge and spending a valuable time on this program. And also the KSM President, Professor Manjula Artigala, and all the KSM council members, and also the Dr. Manjula Caldera for coordinating this very well and for this workshop. Of course, all the participants, both physical and online participants, and your participation is the main successful for this program. And thank you very much, and keep in touch in the Kandy Society of Medicine for future workshops and the symposium coming, and the main annual academic session in end of the March. And of course, the physical and virtual platform. And to make this event in a successful one, the technical and IT support is very important. And Mr. Bandara and the team, thank you very much. And we really appreciate your dedication. And also our main sponsors, Boringers, Enhelmans, and Mr. Rajiv, thank you very much for your valuable contribution, the sponsoring this event. Then finally, Dr. Saman Senanayaka, who they provide this venue for us to conduct this session. And thank you very much, all of you, once again. We'll meet again on another symposium will be organized by the Kandy Society of Medicine.